to welcome you to the 6th International Conference Interprofessional Collaboration and Community Empowerment. My name is Witri Priyawanti Putri. I will be your host for today's International Conference. To the Honorable Excellencies, Director General of Health Workers, Ministry of Health Republik Indonesia, Director of Polkesban Kemenkes Bandung, Honorable Speakers, Honorable Moderators, Project Officers, and Committee of today's International Conference, Excellencies, distinguished guests, participants, ladies and gentlemen. Raise and get gratitude, let us pray to God Almighty for every seat that has been filled here is only because of His guidance and wisdom. May this international conference be a meaningful discussion for all of us. Ladies and gentlemen, today's international conference is held by Poltekkes Kemenkes Bandung. The main topics of today's international conference is preventing and managing diabetes mellitus through multidisciplinary approach, optimizing local materials, resources, applied health science, and community empowerment. This conference to bring together all the academicians, researchers, students, and practitioners who are interested on preventing and managing diabetes mellitus through multidisciplinary approach. This conference provides a great opportunity for all participants to gain our knowledge in terms of managing diabetes mellitus. This conference will feature presentation by international speakers, which are cutting-edge sessions topics. So ladies and gentlemen, today we will have 6 amazing topics that will be delivered by 6 speakers. The topic will be divided into the morning session and also the afternoon session, so make sure that you will stay with us until the end of the conference. Ladies and gentlemen, now I would like to invite all the participants to sit properly for the Indonesian National Anthem.
Politeknik Kesehatan Kemenkes Bandung adalah perguruan tinggi vokasi yang merupakan unit pelaksana teknis dari Kementerian Kesehatan Republik Indonesia yang berada di Kota Bandung, Provinsi Jawa Barat. Sejalan dengan moto Kota Bandung, yakni Bandung Juara, Poltekkes Kemenkes Bandung menjadi bagian yang mendukung moto tersebut. Poltekkes Bandung juara tentunya bukan hanya slogan. Berbagai upaya telah dilakukan untuk mewujudkan dalam bentuk kegiatan-kegiatan seperti pelatihan, seminar atau workshop bagi dosen maupun tenaga kependidikan, baik di tingkat nasional maupun internasional. Selain untuk meningkatkan kompetensi, pelatihan juga diarahkan untuk memotivasi pegawai Poltekkes Bandung dalam meningkatkan pola pikir dan budaya kerja seperti webinar pembinaan perilaku anti korupsi dan karakter melayani dengan hati di lingkungan Poltekkes Kemenkes Bandung dengan mengundang narasumber tim ISQ. Dosen Poltekkes Bandung sebagai agen pelaksana Tridharma perguruan tinggi telah menunjukkan kinerja yang profesional dengan menjalankan tugas dan kewajibannya dalam pendidikan, penelitian, dan pengabdian masyarakat berbasis inovasi keunggulan perguruan tinggi dan pendekatan kebutuhan masyarakat dalam bidang kesehatan. Hal ini dilandasi dengan prinsip melayani dengan hati sebagai implementasi dari pembangunan zona integritas menuju wilayah bebas dari korupsi. Melayani dengan hati mengandung makna bahwa setiap pelayanan yang diberikan kepada user dan stakeholder selalu berprinsip handal, akuntabel, transparan, dan berintegritas. Hal ini tercermin dalam maklumat pelayanan publik Poltekkes Kemenkes Bandung. Poltekkes Kemenkes Bandung telah berupaya dengan keras untuk mewujudkan pelayanan terbaik dengan meraih berbagai prestasi, di antaranya sebagai institusi yang tersertifikasi ISO 9001, mendapat predikat terakreditasi B dari BAN PT, institusi dengan peringkat akreditasi program studi dengan predikat unggul A sebanyak 80%, serta menjadi salah satu institusi yang meraih penghargaan terbaik kedua nasional untuk kategori produk unggulan terbaik. Poltekkes Kemenkes Bandung memiliki sumber daya manusia dan infrastruktur yang memadai. Banyak prestasi yang telah dihasilkan tenaga kependidikan, di antaranya Pranata Laboratorium terbaik kedua tingkat nasional, Pustakawan terbaik tingkat nasional, pembuatan pelaporan keuangan BLU terbaik kedua tingkat nasional. Selain tenaga kependidikan, tenaga dosen di Poltekkes Bandung juga meraih prestasi sebagai dokter termuda dari Muri. Kiprah dosen Poltekkes Bandung di bidang ilmiah menjadi bukti kinerja profesional dosen. Para dosen seringkali dipercaya menjadi narasumber dalam berbagai kegiatan di tingkat nasional dan internasional. Sebagai bentuk komitmen memberikan layanan prima yang transparan, publik dapat mengakses layanan yang disediakan secara luas melalui berbagai media informasi yang dimiliki Poltekkes Kemenkes Bandung. Poltekkes Kemenkes Bandung juga menerapkan layanan dengan prinsip akuntabel dan profesional melalui berbagai aplikasi seperti sistem penilaian kinerja pegawai atau SIKAP, presensi berbasis GPS, website, Learning Management System atau LMS, manajemen kelas, dan media sosial. Inovasi lainnya untuk memberikan layanan prima kepada masyarakat, yaitu tersedianya perpustakaan terpadu, tersedianya laboratorium terpadu, SIAKAD. Selain untuk mahasiswa dan dosen, aplikasi ini juga dapat diakses oleh orang tua mahasiswa sebagai keterbukaan informasi dan juga sebagai fungsi kontrol dari masyarakat. Keberhasilan institusi pendidikan Poltekkes dalam mengemban amanah mencerdaskan kehidupan bangsa dapat dilihat dari output yang dihasilkan atau dari kualitas lulusan Poltekkes Kemenkes Bandung dalam bidang pendidikan. Meraih hasil yang membanggakan yaitu berhasil meraih kelulusan 100% pada saat uji kompetensi mahasiswa dari berbagai program studi. Poltekkes Bandung turut berkontribusi dalam upaya pencegahan dan penyebaran virus corona. Oleh karenanya, Poltekkes Kemenkes Bandung mendapat anugerah penghargaan dari Kementerian Kesehatan sebagai Biosafety Laboratory Level 2. of Excellence, Bandung Health Polytechnic proudly present. Center of Excellence for Applied Science and Technology Polytechnic is a research center in the Health Polytechnic independently and in collaboration with other institutions that carry out applied health research activities. These are some of our products. Development strategies of Center of Excellence. First, institutional strengthening, such as decree, vision, mission, guidelines, roadmap, SOP, building and exhibition venue. Second, research and development and also application of research. They are new research or strengthening of existing research. Third, human resource development, including increasing research skills, production skills, marketing skills, and also training seminars. Fourth, partnership network development, including research and marketing cooperation for domestic and international products. The last, dissemination of research for national, international seminar and product exhibition, and also COE special journal. Membership of Center of Excellence are Department of Medical Laboratory Technology, Department of Environmental Sanitation, Department of Nutrition, Department of Nursing, Department of Pharmacy, Department of Dental Health, Department of Midwifery, Department of Health Promotion, Bogor Nursing Study Program, Bogor Midwifery Study Program, and Karawang Midwifery Study Program. Center of Excellence is one of the organizations that focused on developing and research about science and technology and utilization the local material. Institutional characteristic, they are competitive advantage, strategic value, transfer of technology and knowledge, strong and sustainable institutions, become a national reference, world class, and being the pride of the nation. Field of development of Center of Excellence Bandung Health Polytechnic is to be the leading center for the utilization of local materials to improving health degree and community empowerment. The Center of Excellence does not only innovate the use of local products. The product will then be displayed at the exhibition to introduce the innovation product. The Center of Excellence, Bandung Health Polytechnic, actively exhibits the product in the international exhibition or symposium. The institutional synergy in higher education is to capable in the global competitiveness that involved institution, higher education and training, technology readiness, and innovation. In the future, the Center of Excellence is expected to be able to support a nation that is competitive in the world globally.
Yeah, thank you for the committee for playing the video profile of Poltekkes Kemenkes Bandung and also the video profile of PUI Poltekkes Kemenkes Bandung. Excellencies, participants, ladies and gentlemen, we are now going to listen to the report speech that will be delivered by the chairman of today's international conference, Mrs. Apiti Widyastiwi MSc. So let's give a warm applause for Mrs. Apiti Widyastiwi MSc.
Okay, thank you very much, Mrs. Fitri. Okay, everyone, Assalamualaikum warahmatullahi wabarakatuh. Good morning, distinguished guests, esteemed speakers, and all participants. I'm honored to stand before you today as we gather virtually in this sixth international conference on interprofessional health collaboration and community empowerment. This event marks a significant milestone in our ongoing commitment in fostering knowledge exchange and collaborative learning in the healthcare systems. This year's conference themes is preventing and managing diabetes mellitus through multidisciplinary approach, optimizing local and material resources, applied health science, and community empowerment. This theme highlights the significance of collaboration between health workers, not only to understand the intricacies of this condition, but also to foster a collective responsibility in addressing it. Mr. Director, please allow me to report about the event. In this event, there were about more than 300 participants who registered in this event from across Indonesia, like Java, Sumatra, Borneo, and Sulawesi region, and also from our sister country, Malaysia. And throughout the session, we will have the privilege of hearing from 6 distinct speakers, each bringing their unique and experience and expertise from Malaysia, Indonesia, and Philippines, and also Finland. And in this event, participants also can engage in expert session led by lecturers and members of the academic community from the Poltekkes Kemenkes Bandung, which can provide valuable insight to enhance our understanding about diabetes mellitus. And this agenda also includes an innovative product exhibition and also oral and poster presentation as an opportunity for researchers to disseminate the various research from participants from diverse regions. And dear participants, I encourage you to actively participate in the discussion, ask questions, and engage with our speaker and fellow participants, because your viewpoints and contribution is essential to enhance richness of experience. So, ladies and gentlemen, before we start our discussion, I also want to thank the organizer, especially Center of Excellence Poltekkes Kemenkes Bandung, and also Center of Research and Community Services and Poltekkes Kemenkes Bandung, to all speakers and to all of you, dear participants, for making this event happen. So without further ado, let's embark our journey to explore, learn, and find inspiration in collaborative approach to prevent and manage diabetes mellitus. May this conversation today ignite a new idea regarding diabetes management and to set the stage for positive change in the way we approach and address this critical health issue. Thank you very much for your attention, and let's make this conference a truly enriching experience for everyone involved. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Mrs. Apiti Widyasti MSc, for your brief report. And now, ladies and gentlemen, may I repeat? And now, we would like to invite the Director of Poltekkes Kemenkes Bandung, Mr. Pujiono SKMMKes, to give his welcoming speech. Ladies and gentlemen, please give a warm welcome for Mr. Pujiono SKMMKes.
Ya, terima kasih. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Pertama-tama, marilah kita panjatkan syukur alhamdulillah kepada Allah Subhanahu wa taala, karena atas berkat rahmatnya kita bisa bersilaturahmi dalam rangka webinar internasional Poltekkes Kemenkes Bandung. Yang kami hormati Ibu Dirjen, Direktur Jenderal Tenaga Kesehatan, Kementerian Kesehatan, para narasumber, para pengelola di tingkat direktorat, jurusan, kemudian dosen dan tendik, serta seluruh peserta webinar internasional ke-6 Poltekkes Kemenkes Bandung. Ladies and gentlemen, good morning. I am truly honorable and privileged to welcome each and every one of you to the 6th International Conference on Interprofessional Health Collaboration and Community Empowerment. This event, organized by the Center of Excellence Balok Dayamas and the Center of Research and Community Services of the Poltekkes Kemenkes Bandung, stand as a testament to our collective commitment to expand healthcare through collaboration, innovation, and community empowerment. Our theme for this year conference is preventing and managing diabetes mellitus through multidiscipline approach, optimizing local maternal research, applied health science, and community empowerment. Underscores the critical importance of a holistic, multidisciplinary approach in addressing the challenge posed by diabetes mellitus. I extend a warm welcome to our distinguished guests, including the Director General of Health Workforce from the Ministry of Health, esteemed faculty members, dedicated healthcare professionals, and the bright mind among our students who represent the future of healthcare. In conjunction with this conference, we are privileged to witness the signing of the Memorandum of Understanding extension between Poltekkes Kemenkes Bandung and Edu Excellence from Finland. This partner exemplifies our commitment in fostering global collaboration, education, and research opportunity, ultimately benefit our students and contributing to advance in health science. Thank you for your attention. Thank you for everyone. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Mr. Pujono SKMMKes, for the warm welcome speech. And now, ladies and gentlemen, we will proceed to the next agenda. There will be MOU extension signing between the Poltekkes Kemenkes Bandung with Edu Excellence Finland. Subject of this MOU that the both parties pursue cooperation in respect of three pillars of higher education, or we call it Tridharma Perguruan Tinggi in Bahasa, including education, research, and community services, which includes the following, such as webinars and seminars, consultation, teacher training, intensive courses, and other matters that mutually agree upon. In recognition of their common interest in developing bilateral relations and being convinced that cooperation between the parties contributes to cultural enrichment, scientific progress, and the consolidation of friendship, Edu Excellence and Poltekkes Kemenkes Bandung agree to cooperate in accordance with following certain principles and conditions. And now we would like to invite the director of Poltekkes Kemenkes Bandung, Mr. Pujiono, and the representative of Edu Excellence from Finland, Mr. Immanuel Sine, to sign the MOU in their respective places, because currently Mr. Pujiono is in Bandung, meanwhile Mr. Immanuel Sine in Finland. So, ladies and gentlemen, please let us see the MOU extension signing between the Poltekkes Kemenkes Bandung and Edu Excellence Finland.
Okay, thank you very much, Mr. Melek. Okay, thank you very much.
Okay.
Hello, this is my part.
Okay. Dilihatin dulu kan? Okay. Thank you for signing the document. For the documentation, we invited both parties to stand up and also show the signed MOU to the cameras. Once again, Mr. Director, please stand up and show the signed MOU to the camera, so the participant will also can see the MOU sign. Okay. Thank you so much. So before we close the MOU extension signing between Poltekkes Kemenkes Bandung with Edu Excellent Finland, we would like invite the representative from Edu Excellent Finland, Mr. Immanuel Sine, to deliver his probably a short speech on impressions and also message for this MOU extension. For Mr. Immanuel Sine, please welcome.
Good morning, everyone. Greetings
morning.
from the happiest country is Finland.
Good
And
morning.
first of all, Edu Excellent would like to thank and highly appreciate about the cooperation with the Bandung Polytechnic of Health since 2021. And secondly, the implementation of the first MOU, it's create three things about Edu Visit, general lecture, and then international webinar. Thirdly, the second MOU, we would like to create the concrete and then sustainable matters that benefit for mutual benefit for us and bless especially for the Bandung area, East Java and Indonesia and across the globe by the mutual benefit of cooperation with many things. And we know that health issue now it's more and more needed. So I think collaboration with Edu Excellent Finland and other party, I think we would like to bless others and especially for Bandung Polytechnic of Health. And finally, on behalf of Edu Excellent Finland, congratulations and success for this conference. And finally, terima kasih and thank you.
Thank you.
Thank you.
Thank you.
Kitos. Kitos.
Thank you so much,
Salas.
Mr. Immanuel Sine, for your speech. There will be the closing of this MOU signing between Poltekkes Kemenkes Bandung with Edu Excellent Finland. And now, ladies and gentlemen, distinguished guests, before we proceed further, let us pray together for today's events. I would like to invite Mr. Ujang Nurjaman, SKMNkes, to lead our prayer for today. To Mr. Ujang Nurjaman, the time is yours.
Ya.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam
Waalaikumsalam
warahmatullahi wabarakatuh.
Good morning and greeting to all. Let's thank to God. This morning we can meet together in Good morning and greetings to all. Let's thank to God. This morning we can meet together in 6th International Conference on Interprofessional Health Collaboration and Community Empowerment with Poltekkes Bandung. Before this conference start, let's pray fervently for each religion. Allow me to guide you all, pray according to the guidance of Islam. A'udzubillahi minasyaitonirrajim. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Allahumma sholli ala sayyidina Muhammad wa ala ali sayyidina Muhammad. Wa sallim wa radhiyallahu tabarakta an kulli sahabati Rasulillah ajmain. Amin ya Allah ya rabbal alamin. Alhamdulillahirabbil alamin. Hamda syakirin, hamdan na'imin, hamda yuafi ni'amahu wa kafi mazidah. Ya Rabbana lakal hamdu kama yang bagi li jalali wajhikal karim wa alim sultanik. Allahumma tawil umurana wa sahhi ajsadana wa nawwir qulubana wa thabit imanana wa ahsin a'malana wa wasi arzaqana wa ilal khairi qarribna wa anish syari abidna wa qdi hawaijana fid dini wa dunya wal akhirah. Ya Allah, there are two words and feelings that we deserve to convey to you this morning. Accept our gratitude for all blessing and guidance that you have given us so that we can event together in this international conference. Ya Rahman, please make this conference getting your blessing, mercy, and guidance. Ya Rahim, please grant us good innovation in every task execution. Give us health, strength, and ability so that we are able to carry out the duties and responsibilities for the good and benefit for our community, nation, and country. Ya Hafid, Ya Majid, unite for our heart, our step, and grow a sense of brotherhood, keep our soul in purity, and decorate our moral with exemplary. Only to you we worship, ask forgiveness and help. Ya Allah, please accept our prayer and supplication. Amin ya Allah ya Rabbal Alamin. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi.
And gentlemen, thank you for Mr. Ujang for lead our prayer for today's event. Ladies and gentlemen, for the next agenda, there will be a photo session. For the photo session, I would like to invite all the participants in this Zoom meeting platform to open your camera. So we have several slides at this time. And I will begin with the first slide and then continuing until we're reaching our last slide. Ladies and gentlemen, please keep your smile until the end of the slide because we don't know where your screen is. Okay, let's start the documentation from the first slide. 1, 2, 3. The second slide. The third slide. And fourth. Okay, that will be the end of our documentation session. Thank you for joining our photo session, ladies and gentlemen. And now, before progressing our agenda, let me read our event rules as follows. Our event will be held for 2 days, into 22 until 23 November in 2023. The first day agenda will consist of the main session in the morning, followed by the plenary session in the afternoon. And the second day, the agenda will consist of virtual open house and also expert session, poster session, and also oral presentations. Participants can join in this international conference by using Zoom Cloud meeting platform for the first 1,000 participants. And for the rest, participants can access it through our YouTube channel, Media Poltekkes Bandung. Participants are required to rename the Zoom account into country_real name during this virtual meeting. For example, Indonesia_Witri Priawanti Putri. Participants are requested to deactivate the microphone during the session. And the participant can also ask the speakers via chat box in the Zoom meeting by following the format. For example, name_country_speakers, and then name of the speakers, and then underscore the questions. Attendance form will be delivered in the chat box after opening. After the opening. Meanwhile, the evaluation form will be delivered after the discussions. And the certificate requirements are as follows. The first, participants should attend the first and the second day of the conference. The second, participants should fill in the attendance and evaluation forms. The third one, participants should fill full name in capital letter in attendance and also the evaluation forms. So that's the rule of our international conference. Thank you for your attention. Now, And now, we would like to play for you some video from the community. Please enjoy.
Politeknik Kesehatan Kemenkes Bandung adalah perguruan tinggi vokasi yang merupakan unit pelaksana teknis dari Kementerian Kesehatan Republik Indonesia yang berada di Kota Bandung, Provinsi Jawa Barat. Sejalan dengan moto Kota Bandung, yakni Bandung Juara, Poltekkes Kemenkes Bandung menjadi bagian yang mendukung moto tersebut. Poltekkes Bandung Juara tentunya bukan hanya slogan. Berbagai upaya telah dilakukan untuk mewujudkan dalam bentuk kegiatan-kegiatan seperti pelatihan, seminar atau workshop bagi dosen maupun tenaga kependidikan, baik di tingkat nasional maupun internasional. Selain untuk meningkatkan kompetensi, pelatihan juga diarahkan untuk memotivasi pegawai Poltekkes Bandung dalam meningkatkan pola pikir dan budaya kerja seperti webinar pembinaan perilaku anti korupsi dan karakter melayani dengan hati di lingkungan Poltekkes Kemenkes Bandung dengan mengundang narasumber tim ISQ. Dosen Poltekkes Bandung sebagai agen pelaksana Tridharma perguruan tinggi telah menunjukkan kinerja yang profesional dengan menjalankan tugas dan kewajibannya dalam pendidikan, penelitian, dan pengabdian masyarakat berbasis inovasi keunggulan perguruan tinggi dan pendekatan kebutuhan masyarakat dalam bidang kesehatan. Hal ini dilandasi dengan prinsip melayani dengan hati sebagai implementasi dari pembangunan zona integritas menuju wilayah bebas dari korupsi. Melayani dengan hati mengandung makna bahwa setiap pelayanan yang diberikan kepada user dan stakeholder selalu berprinsip handal, akuntabel, transparan, dan berintegritas. Hal ini tercermin dalam maklumat pelayanan publik Poltekkes Kemenkes Bandung. Poltekkes Kemenkes Bandung telah berupaya dengan keras untuk mewujudkan pelayanan terbaik dengan meraih berbagai prestasi, di antaranya sebagai institusi yang tersertifikasi ISO 9001, mendapat predikat terakreditasi B dari BAN PT, institusi dengan peringkat akreditasi program studi dengan predikat unggul A sebanyak 80%, serta menjadi salah satu institusi yang meraih penghargaan terbaik kedua nasional untuk kategori produk unggulan terbaik. Poltekkes Kemenkes Bandung memiliki sumber daya manusia dan infrastruktur yang memadai. Banyak prestasi yang telah dihasilkan tenaga kependidikan, di antaranya Pranata Laboratorium terbaik kedua tingkat nasional, Pustakawan terbaik tingkat nasional, Pembuatan pelaporan keuangan BLU terbaik kedua tingkat nasional. Selain tenaga kependidikan, tenaga dosen di Poltekkes Bandung juga meraih prestasi sebagai dokter termuda dari MURI. Kiprah dosen Poltekkes Bandung di bidang ilmiah menjadi bukti kinerja profesional dosen. Para dosen seringkali dipercaya menjadi narasumber dalam berbagai kegiatan di tingkat nasional dan internasional. Sebagai bentuk komitmen memberikan layanan prima yang transparan, publik dapat mengakses layanan yang disediakan secara luas melalui berbagai media informasi yang dimiliki Poltekkes Kemenkes Bandung. Poltekkes Kemenkes Bandung juga menerapkan layanan dengan prinsip akuntabel dan profesional melalui berbagai aplikasi seperti sistem penilaian kinerja pegawai atau SIKAP, presensi berbasis GPS, website, Learning Management System atau LMS, manajemen kelas, dan media sosial. Inovasi lainnya untuk memberikan layanan prima kepada masyarakat, yaitu tersedianya perpustakaan terpadu, tersedianya laboratorium terpadu, SIAKAD. Selain untuk mahasiswa dan dosen, aplikasi ini juga dapat diakses oleh orang tua mahasiswa sebagai keterbukaan informasi dan juga sebagai fungsi kontrol dari masyarakat. Keberhasilan institusi pendidikan Poltekkes dalam mengemban amanah mencerdaskan kehidupan bangsa dapat dilihat dari output yang dihasilkan atau dari kualitas lulusan Poltekkes Kemenkes Bandung dalam bidang pendidikan. Meraih hasil yang membanggakan yaitu berhasil meraih kelulusan 100% pada saat uji kompetensi mahasiswa dari berbagai program studi. Poltekkes Bandung turut berkontribusi dalam upaya pencegahan dan penyebaran virus corona. Oleh karenanya, Poltekkes Kemenkes Bandung mendapat anugerah penghargaan dari Kementerian Kesehatan sebagai Biosafety Laboratory Level 2.
Okay, thank you, committee, for playing again the video. Ladies and gentlemen, initially we will have a keynote speech from Dr. Gigi Arianti Anaya MKM, but due to another business, so we just continue the event, and we have arrived at the main event of this international conference, the presentations of material by awesome speakers, as well as discussion sessions that will be guided by our moderators. For the first session will be moderated by Mrs. Apiti Anggraini Ayuhastuti MSc. Mrs. Apiti Anggraini Ayuhastuti MSc currently work as a lecturer in Pharmacy Department, Bandung Health Polytechnics. So, ladies and gentlemen, without further ado, please welcome our extraordinary moderator in this first session, Mrs. Apiti Anggraini Ayuhastuti MSc Apiti. The time is yours.
Well, thank you very much for the kind introduction, Mrs. Witri. Well, Assalamualaikum warahmatullahi wabarakatuh to all participants. Ladies and gentlemen, welcome to the main session this morning virtual event. Today, we will hear lectures from three outstanding speakers whom expert in healthcare field, especially diabetes mellitus treatment. For the first speaker, we are very delighted and feel fortunate for today as we welcome Professor Dr. Zarina Awang from Lincoln University, Malaysia as our first speaker with a lecture with the title of Current Update on Diabetes Mellitus Prevention and Management. Before that, good morning, Professor. How are you?
Good morning and
Professor
Assalamualaikum.
Zarina.
Okay. Thank you.
Waalaikumsalam. Thank you, Professor, for here today. Well, before Professor proceed with the lecture, let me read Professor Zarina's CV. Currently, Professor Zarina serves as a Dean at the Medical Faculty at Lincoln University College, Malaysia. She earned MD degree from the National University Malaysia in August 1986, Master of Medicine Anesthesia from UKM, National University of Malaysia in 1994, and Master of Science in Healthcare Management from University of Wales, Swansea, UK in 2002. She began her career from 1993, then became a specialist in anesthesia critical care at Hospital Kuala Lumpur. She served as Managing Director at private hospital Danau Kota Kumpulan Perubatan Zazali. She was lecturer emergency medical at UPN and lecturer in clinical therapeutic and pharmacology anesthesia at Lincoln University. She also currently serving as a dean at medical faculty at Lincoln University College. She is actively involved in many professional organizations such as National Specialist Register or NSR, Malaysia Medical Council or MMC, Malaysian Society and Anesthesiology, MSA, and many more. Well, her remarkable experience and dedication in the healthcare field in Malaysia and Asia are truly outstanding. Well, then let's welcome Professor Zarina Awang.
Thank you very much, Dr. Angrini.
Professor, please proceed with your lecture.
Okay. I would like to request for the slide presentation as I go along this discussion for today's topic. May I have may I share the slide, or the committee would like to share the screen for me? Okay, never mind. I will use my own.
Okay.
Okay, thank you very much. Okay. I'm Dr. Zarina Awan, the Dean of Medical Faculty. Thank you for the introduction by Dr. Angrini. Okay, so this is the picture of Lincoln University College, the campus in Kuala Lumpur, Kelana Jaya. I am stationed at Kelana Jaya in Selangor. So, next slide. So the topic given to me is on the current updates on diabetes mellitus, prevention and management. So essentially, I will share with you on the preventive. Okay, let me see. I have problem with, okay. So the first thing that I would like to highlight here is, despite new treatment classes in controlling the hyperglycemia for patients with diabetes, it has been shown that the treatment has been suboptimal globally, not only in Malaysia. And because of this, it has been associated with a high risk of premature mortality related to diabetes when we talk about the complication in the microvascular as well as macrovascular. This is point number one. Now, point number two is the practice guideline is typically focused on the HbA1c. And the target at this point is to keep the HbA1c less than 7% as the therapeutic goal in type 2 diabetes. I am emphasizing more on type 2 diabetes because it has been shown that 90% of all types of diabetes the incidence is high among type 2 diabetes mellitus. So the treatment strategies are both towards glucocentric as well as cardio-renal centric treatment strategies to ensure that we will reduce the cardio-renal diseases related to diabetes. The fourth statement that I would like to make is that the practice guidelines developed in USA and Europe may not be applicable for us in Asia because we have different epidemiology, patient phenotypes, our culture, our resource availability, and treatment affordability. So the bottom line at the end of the session, we have to decide on the cost of treatment of this chronic illness that is diabetes mellitus. Next slide, please. Okay. Now, the World Diabetes Day was celebrated on the 14th of November every year, and we need to emphasize a few things during this World Diabetes Day. One is the access to diabetic care we must ensure that everyone deserves this diabetic care. The understanding of prevalence by the paramedics must be known, okay, because 1 in 10 adults worldwide have diabetes. Okay, this is a very high number, 1 in 10. And the complication associated with it and the warning signs for diabetes must be made known, not just to the healthcare providers, but also to the patients suffering from diabetes. Now, in this area of discussion, I will highlight a bit on what is diabetes, what is the epidemiology, how to diagnose diabetes, and the treatment of diabetes. In this treatment of diabetes, essentially the area that we need to emphasize is the lifestyle change. Then only we go to the pharmacological component of it, which will start as monotherapy, combined therapy among the oral hypoglycemic drugs, or a combined therapy with the OHA and the insulin, and what are the complications and treatments of these complications. So what is diabetes? The American Diabetic Association defines diabetes as a group of metabolic disease characterized by hyperglycemia. So you need to have at least a glucometer to show the levels, and as paramedics, we as healthcare providers, we must know what are the normal levels before we can confirm them as diabetes. And these hyperglycemia results from defect in insulin secretion, insulin action, or both. So every diabetic patient is different, and the treatment need to be tailor-made towards them. Now, the chronic hyperglycemia is the problems actually because it causes long-term damage, dysfunction, and the organs that we need to pay particular attention are the eyes, kidneys, heart, and blood vessels. Even though you know that there are several types of diabetes, type 1, type 2, maturity onset diabetes of the young, gestational, neonatal, and secondary causes, type 2 diabetes mellitus is the highest, has the highest incidence. Now, if you look at the global projection for diabetes, in the year 2003 and projected in the year 2025, if you look at Southeast Asia, in the year 2003, there is 39.3 million people with diabetes. And by the year 2025, it is projected that 81.6 million will have diabetes. That is an increase by 108%. As seen in worldwide, the increment is only 72%. So Southeast Asia is considered a high-risk area or the high incidence area for diabetes. So if you look at these countries, Pakistan is number 1 with 31% population with diabetes. And here, Malaysia falls number 16 with the 19% population with diabetes. This is the statistic in the year 2020. Sorry. So if you look at the Asia continent, Malaysia falls number 1, followed by Singapore, India, China, Taiwan, Korea, Japan, and Indonesia here is about half of the levels prevalence of diabetes in the country. So HbA1c has been used for monitoring, and it has been shown that the higher the level of HbA1c, the higher the incidence of myocardial infarction as well as microvascular diseases. So these are the complications of diabetes: macrovascular, microvascular. One of the chronic complication diabetes as seen here is diabetic retinopathy. Stroke, heart attacks, peripheral artery diseases are a chronic complication of long-standing diabetes. Now, what about diabetes in Malaysia itself? It is discovered that incidence is very high. 1 in 5 people has diabetes. And the prevalence has increased about 7 times over the last 50 years. Now, what are the pathogenesis of diabetes? As you know, the organs that secrete insulin is from the pancreas, from the beta cells. The pathogenesis ranges from the autoimmune destruction of beta cells or deficient action of insulin on target cells. Now, looking at the pancreas, it has exocrine function as well as endocrine function, where about 70% of beta cells synthesize and secrete insulin. So other than that, it's about 15 to 20% of the cells secrete glucagon. These are the main players in the regulation of insulin. Regulation of glucose, sorry. Now, so what are the insulin function? One of it is to facilitate the transport of glucose from the bloodstream to muscle and fat cells. Know that insulin is a polypeptide hormone produced by beta cells, islets or Langerhans of pancreas. So it is an anabolic hormone which work along a specific receptors on the cells, as seen here in this diagram. So my discussion here will be about management and treatment of type 2 diabetes. The most important thing is to correctly diagnose diabetes and then the lifestyle changes is also considered therapeutic because it might be commonly associated with lifestyle of every individual. Then we go into the pharmacology, either monotherapy, combination therapy with oral drugs, or combination therapy with insulin. So the diagnosis type 2 diabetes mellitus is very important by taking a detailed history and doing a thorough physical investigation. Here, we need to know what are the baseline investigation to assess the atherosclerotic cardiovascular disease risk factors that will determine the complication of the type 2 diabetes mellitus. Again, here is written management again involve lifestyle modification as well as encouraging patient primary education, self-care and empowerment other than medication by the healthcare provider. Now, what are the values for diagnosis? Okay, the values for any patient for the first time, we must do at least 2 sampling of blood glucose level. So for those people who have a fasting more than 7 millimole per liter, or a random of more or equal of 11.1 millimole per liter, and then after a repeat of the same test with this same level, it can be a diagnostic value for type 2 diabetes mellitus based on venous plasma glucose. Now, for the pre-diabetic, based on HbA1c, if the HbA1c is more than 6.3, as seen here, this is again another criteria to suggest the patient is a diabetic. Normal patients should have HbA1c less than 5.7, and the pre-diabetic more than 5.7 or less than 6.3% is regarded as pre-diabetic, and majority of them over time will become a diabetic patients. So these are the OGTT tests. Okay, a normal patient, a fasting level should be less than 6.1, a 2 hours postprandial should be less than 7.8, and then the intermittent fasting glucose falls under this range. And for diabetic, again, like I mentioned earlier, fasting is more than 7 and 2 hours postprandial is more than 11.1. So what to do in the management of new patients suspected of diabetes? So you need to take the height and weight, waist circumference to determine the BMI, because the treatment for patient who has normal weight, obese, tend to differ slightly. And then always check whether the blood pressure is normal, because abnormal blood pressure will cause an earlier complication to the other end organs. Eye examination is also mandatory first visit or on an annual visits. The feet is also important other than dental checkup and ECG. These are done initial visits and on an annual visits. Other than that, what are the laboratory investigation? HbA1c is mandatory, followed by the other investigation like lipid profiles, renal profile, liver function test, urine test. All these are to see whether there are any end organ complications brought about by diabetes. So these are the targets. So the targets for fasting in patients who've been treated for diabetes, we need to target less than 7, but more than 4.4. Hypoglycemia is also another complication with over-treatment. So they must have a range for targets. And HbA1c, the target is variable between 6.5 to 7. In healthy patient, the target should be lower, but in a high-risk patient, you can go as high as 7. Other than that, blood pressure, make sure that it is less than 140 for systolic and less than 80 for diastolic. For the patient, encourage them to exercise about 20 to 30 minutes per day. And the body weight, whatever the weight, especially for the obese and overweight patient, to reduce 10% of the weight in about 6 months. So you need to work out on how much to lose per month and what are the exercises that can help them to reduce this weight. Sorry, there's some problem with the slide changer. Excuse me, can
Yes, Professor. Can we
yes,
help you? Professor?
okay, it was written here that somebody else is sharing the slide. So may I know? Okay, so I can change the slide.
I'm sorry, Prof. Next or before?
Pardon? Can you share the slide instead of me?
Oh, not from me?
Because it's mentioned here there's two people sharing the slide, so I could not move to the next slide.
Oh, okay.
So my apologies. Okay, thank you.
Yeah.
Okay, the next thing is monitoring of diabetes. The monitoring is through HbA1c. These are actually a predominant form of glycated hemoglobin present in the red blood cells. Okay, and it is formed when the normal hemoglobin A reacts with non-enzymatically with glucose. So since it remains in the circulation for 3 months, usually the levels reflects the content of the HbA1c in the last 3 months. Next, please. Okay, so what are the targets based on patient profile? Okay, as you can see here, if the patient is a newly and recently diagnosed diabetes mellitus, younger age group, healthier with no evidence of complication, with low risk of hypoglycemia, always have a tight control. The aim is to keep the HbA1c less than 6.5 or equal to 6.5. Whereas in elderly patients with have comorbidities, high risk of hypoglycemia, and you feel that a patient might have short life expectancy, the HbA1c control is less tight. Keep it between 7.1 to 8%. However, for those in between this type of patient, the aim is to prevent complication or to stabilize the comorbidity. Next slide, please. Okay, this is the important chart. This chart is about the oral anti-diabetic drug. I'm saying just the oral medication. Essentially, the mechanism of action falls under 4 categories. One is the insulin sensitizer. The popular one is the biguanide, metformin. I will emphasize a bit on metformin. Okay, in those patients who are allergic to this group, they may consider thiazolidine. Okay, the other group is called insulin secretagogue. Okay, the 3 important area is sulfonylurea, which is commonly used and prescribed as second-line medication. And then metoclopramide is also one of those available under the same group, secretagogue. And these are the currently popular drug, the DPP4 inhibitor. So these are the newer group of drug which we will emphasize today. The third mechanism of action is by reducing intestinal absorption of glucose. This is the AGI, alpha glucosidase inhibitor. It is quite an old drug, not popular anymore, but it has its own role on its own. Lastly is by increasing excretion of glucose from the urine. Now this is also another group that is popular these days, the SGLT2 inhibitor, which I will discuss subsequently. So if you look at the mechanism action, it's either increase insulin secretion, increase glucose uptake, or delay glucose absorption. And the fourth one, not seen in this diagram, is increase glucose excretion in the urine. So if you look at the classification of anti-diabetic drug, this includes oral as well as injectable. I've mentioned earlier these three groups: A, insulin secretagogue, insulin sensitizer, alpha glucosidase inhibitors are mainly oral drugs, whereas the incretin modulator, it has injectable as well as oral. Amylin analog is something new. It is mainly injectable form. So let's look at metformin. These are insulin sensitizer. Most of the physicians will start a patient on metformin for the newly diagnosed diabetes. Now, common side effects of metformin is the GIT, discomfort, nausea, diarrhea, but commonly it will go off after a few weeks. The only thing is that if the patient has kidney, liver, or heart disease, or if the patient is alcoholic, try not to put the patient on metformin. Okay, or if there are situations to stop taking metformin, including if suddenly the patient became unstable and develop heart failure. So metformin is not the choice. But essentially, if these patients are stable, metformin is the first line. The next is thiazolindione. Dines. Okay. Now, the thing is, thiazolindione is also an insulin sensitizer. The famous brand in Malaysia, like Actos or Avendia. So, but the common effect is weight gain. And if there is swelling of the feet and ankle, be very careful. You need to start looking for the early signs of heart failure. And this drug has been associated with certain types of cancer, like bladder cancer and risk of bone fractures. Okay. So if the patient can manage with metformin should be better. Another group of drug is the secretagogue, and the famous one is sulfonylurea group. So this has been used for type 2 diabetes for many years because the effectiveness of lowering of blood glucose is as much as 20%. And this drug is not expensive. It is effective, easily available, and have a very long track record. So, but you need to be cautious in patients with kidney failure. And this sulfonylurea can develop hypoglycemia, especially in elderly patients. Hypoglycemia can be detrimental. The next group, also an insulin secretagogue called DPP4 inhibitor. Okay, the famous one is Januvia, Galvus. These are the ones that is commonly used in my practice. So the patient's lowering effect is due for, the medicine lower blood sugar level by increasing insulin release from the pancreas. Okay, so the good thing about DPP4 inhibitors, it do not cause much hypoglycemia and it does not cause much changes in the body weight. Next group, meglitinides. This is also another insulin secretagogue. The famous one is ripaglinide. Okay, so you may consider using this group of drug if the patient is allergic to sulfonylurea. However, this is not generally used as the first line treatment because of the cost. It is rather expensive, but it is good in patients with kidney failure. Okay, so the next group that I want to highlight is the AGI or alpha glucosidase inhibitor. This is rather an old drug. The commonly used in my practice is acarbose. Okay, so what it does, it interferes with absorption of carbohydrate in the intestines. But the side effects that most patients cannot tolerate is the GIT symptoms like flatulence, diarrhea, greasy stool, and things like that. And this drug need to be given 3 times a day. That is first bite of each meal. Now let's go to the SGLT2 inhibitor or sodium glucose cotransporter 2 inhibitor. So these are the newer generation of drug. The popular one like Jardiance or empagliflozin. Okay, it is similar in potency like the DPP4 inhibitor, and it is a good choice for patients with heart failure or patients with chronic kidney disease because they have been shown to have some cardiovascular, renal, and mortality benefit. So, and the other advantage is it does not cause low blood sugar, and it also causes modest weight loss and blood pressure reduction. Since the excretion is by the kidney, there are some mild side effects like genital yeast infection, UTI in both men and female. And there was some medicine in this class that has been associated with risk of bone fracture. So I hope the audience remember that even though SGLT2 inhibitors are popular these days, but you must remember that it can increase the risk of diabetic ketoacidosis. And this can happen even when blood sugar is only mildly elevated. So this is one thing that you need to be very, very careful with SGLT2. Next, okay. Now, before we go to that, let's look into what is incretin. Now, incretin essentially is gut hormones. Okay, what it does, it augments glucose-stimulated insulin release from the beta cells of the pancreas, and it also inhibits glucagon secretion. This is incretin. Next slide, please. So when we talk about the next group of drugs, incretin modulator, okay, DPP4 falls also under secretagogue, but it is also an incretin modulator. So the popular one like Januvia or sitagliptin. So what it does is it increases both incretin hormones. There are two important incretin hormones, that is the GLP-1, glucagon-like peptide 1, and GIP, glucose-dependent insulinotropic polypeptide. Okay, so these inhibitors will cause an increased concentration of these two hormones. Next, please. Okay, essentially the mechanism of action is that DPP4 enzyme itself inactivate GLP-1. In the presence of DPP4 inhibitor, which block this effect of the enzyme, it will cause an increase in GLP-1, which stimulates insulin secretion and suppress glucagon secretion. So this is one. This is the mechanism of action of this group of drugs. Next, please. So in the injectable form of incretin is called glucagon-like peptide 1 agonist. The popular one is exenamide. It is a long-acting drug. Okay, however, it falls under the expensive group of medication. Next, please. So essentially, this is how it works. GLP-1, it reduces body weight, reduce blood pressure, reduce plasma glucose, reduce plasma lipids. And then it also increases myocardial contractility, reduce the glucose uptake, and it increased ischemic preconditioning factors. Okay, so by increasing in insulin and reducing the glucagon. Okay, next, please. So this GLP-1 receptor agonist is useful in overweight patients. Commonly, it do not cause low blood sugar, but however, generally, it is expensive. Okay. So there are various preparations like the twice daily dosing, extended weekly dosing. So depending on the availability of this agent and the preference of the healthcare provider. Okay, next, please. Now, amylin analogs, the example is pramlintide. This is also another injectable form, synthetic analog of amylin. As you know, the amylin is also a peptide hormone that is co-secreted with insulin from the beta cells of the pancreas. And this has been found to be efficient in diabetic patients. So this drug is still under research because it has been found that in human, it can cause amyloid fiber clotting together. So these things is still under research, and studies has mainly been on animal and not so much on human models. Next, please. Okay, let's go to the next one. What are the therapy? Now, the therapy depends on the HbA1c level. So for newly diagnosed type 2 diabetes, again, we go for monotherapy. We go with what metformin. And then monitoring should be done between 3 to 6 months. If the HbA1c is sustained less than 6.5, then continue lifestyle modification and continue with the treatment. Next, please. However, if it falls between the range of 6.5 to 7.4, you may consider dual therapy, that is metformin combined with any of the other groups that was mentioned just now. Okay, provided there is no end organ problems. Next. Now, if it is more than 7.5, less than 8.4, again, dual combination therapy may be considered and continue the treatment. Okay, and monitoring over 3 to 6 months. Next. Now, HbA1c of 8.5 to 10%, okay, or fasting plasma glucose of 10 to 13 millimole per liter, consider triple therapy in the combination of metformin with any of the groups mentioned. Same principles. Next. If, let's say, for the newly diagnosed diabetes, and you see that HbA1c is more than 10, or the fasting plasma glucose more than 13, you may consider a basal or premix insulin therapy on top of this combination therapy. Next, please. So what are the initiation and optimization of insulin therapy in newly diagnosed diabetes? You may consider straight away to insulin if the patient is symptomatic. They have symptomatic hyperglycemia irrespective of HbA1c. So in other words, there are two groups of people who wait until the very end or who start very early. So either way is okay. So first indication, symptomatic hyperglycemia. Second indication, HbA1c more than 10. Third indication, type 2 diabetes mellitus, already on maximum OGLD with HbA1c, even ideal HbA1c. You may consider insulin therapy. Next. Now, insulin therapy, the treatment at earlier stage may improve overall diabetes management over time. But the thing that is not in favor so much of insulin is because of the incidence of hypoglycemia. So the healthcare provider need to select the patient. Either you want to start early or towards the end. It is at your own preferences. Next. So these are insulin therapy. It can be a short-term therapy or a long-term therapy. So it is up to the physician to decide on this. The commonly short-term therapy are those patients with acute illnesses, pregnancy, or patient who has metabolic decompensations. You have to consider short-term use of insulin therapy. But for long-term insulin therapy, if target has not been reached after optimal dose of this combination therapy. So these are the methods of insulin therapy, and these are the sites that can be used. I'm sure you know. These are the recommended sites where insulin can be injected. Next, please. Okay, again, so what are the complications of insulin therapy? These are all the mentioned complications, but essentially the highest in the list is actually hypoglycemia. So it is important that the family, the healthcare provider inform and educate the patients who are on insulin of all the presentation of hypoglycemia. Next, please. Okay, I just share this this slide about dawn phenomena and Sabatier effect. Okay, so at 3 a.m., commonly there is this phenomena called hypoglycemia. The dawn phenomena as seen here, and this other Sabatier effect. So dawn phenomena is just the normal morning effect of increase. The hypoglycemia is brought about because the increase in growth hormone and insulin level. So whereas Sabatier effect is the rebound hyperglycemia due to hypoglycemia throughout the night. So the treatment differs. So how to differentiate these two is to check the blood sugar level at about 3 o'clock in the morning. If it is high or normal at this time, this indicates dawn phenomena, and low, usually it indicates the Morgay effect. So the treatment need to be adjusted. For the Morgay effect, you may consider decreasing the medication, whereas for the dawn phenomena, you need to consider increasing the medication. So these are the things regarding the use of insulin that need to be informed to the patients or the caretaker of the patients. Next, please. So again, I think I will not go through into this, but you should know that the acute complications other than hypoglycemia includes ketoacidosis, hyperosmolar hyperglycemic non-ketotic syndrome. This is a medical emergency. So if you lose out and you fail to diagnose this, the patient can die. Okay, so let's look into these acute complications and what to do. Next, please. Okay, like I mentioned, hypoglycemia is the frequent acute complications of diabetes. Patient might be missing meal or doing excessive exercise or brought about because of the alcohol ingestion. Next. So again, this is a summary of the microvascular, macrovascular. Next, please. Okay, let's look into diabetic ketoacidosis. So this is a true emergency. Some patients just present with clinical presentation, which you may think that it is an acute gastroenteritis like vomiting, stomach pain, or they become more sleepy. And occasionally, you might have a patient with fruity breath. And when you check the pulse, they tend to be tachycardia. So the signs might not be classical to suggest diabetic ketoacidosis, but patients who are on diabetic medication always rule out diabetic ketoacidosis if they are not well. Next, please. So how to treat DKA? The algorithm is also DKA. That is treatment of dehydration, correction of potassium, correction of anion gap, and then at the same time address the triggering factor like infection, ischemia, intoxication. All these need to be treated. Next, please. Now, what's the difference between DKA and HHS? Even though HHS is not that common, but it is more common in type 2 as opposed to type 1. And the thing about HSS, the mortality rate is high. It can go as high as 40 to 60%. And commonly, it is more common in the elderly. And the thing is, when you check for ketones, usually there is no evidence of ketoacidosis. So, always suspect this acute emergency in patients who has diabetes. Whereas DKA is more common in type 1, but it can also happen in type 2 diabetes. Next, please. So suggested treatment. I'll just go into the normal weight. As you can see, the current treatment, even though metformin is one of the recommended first-line treatment, but for patients with specific profile, you may consider one of the safe drug is DPP-4 inhibitor or sulfonylurea, and if they need a second line, combine with SGLT, third line, combine with GLP-1, and may consider basal insulin. Next, please. Patients who are overweight. If you have a look at this, we realize that patient with a specific patient profile, these newer drugs are relatively safe, GLP-RA, SGLT2. So for those people with coexisting disease, abnormal profile, it is okay for you to move away from metformin unless they have no complications. Okay, next. Okay, so like DKD stage 3 to 4, diabetic kidney disease, SGLT2, you need to stop when starting dialysis. Even GLP-4 is contraindicated if the eGFR is very low. So insulin might be one of the options of choice. So next, please. Now, key messages. Okay, I'm about to finish. These are the few key messages. Now, risk-based screening for pre-diabetic is very important. Or type 2 diabetes mellitus in adult should be screened in all patients more than 30 years of age. And a patient should be encouraged to repeat annually because studies have shown that 50% of people with diabetes are undiagnosed until they develop complication. In fact, they come to see the healthcare physicians because of the complication, not knowing that they have diabetes. Next, please. So this cardiovascular outcome trial has proven that two classes of glucose-lowering drug reduce major adverse cardiovascular events outcome in patients with atherosclerotic cardiovascular disease. Okay, so it has been proven. What is it? The two groups are GLP-1 as well as SGLT2. Okay, so SGLT2 inhibitors have been proven to be renoprotective. It delays progression to end-stage renal failure and more than 40% reduction in EGFR or renal death. So this is the second class of therapy proven to be renoprotective apart from the RAS blocker, renal angiotensin system blockers for hypertension. So next. So in conclusion, the highlights in this presentation is 1 in 10 adults worldwide are living with diabetes, and 90% of these have type 2 diabetes. Okay, and the Asia Pacific accounts for more than 50% of the global population with diabetes. This is where we are residing. And 1/3 of these diabetic-related deaths occurred in productive age group, that is working age people less than 60 years old. Okay, next, please. And then most international, second highlight is most international and regional practice guideline recommend the glycated hemoglobin should be less than 7 as a therapeutic goal for type 2 diabetes. Next. And most CVOT trials confirm the benefit of SGLT2 and GLP-1 receptor agonist in patients who type 2 diabetes with multiple risk factors or complications. So we need to start looking into this group of drugs. Next. So in conclusion, diabetes is a slow killer. We have not yet found a known curable treatment for diabetes. However, early diagnosis can reduce the complication by proper awareness, timely treatment, as well as early diagnosis and treatment. Now, the three major organs that need to be emphasized on is the prevention of blindness, kidney damage, and heart attack. So health education must be conveyed to patients, healthcare providers, so that the capacity building of diabetic health center, we can strengthen diabetic patient association, and more research study can be done on this in this area. So the general goal, may I conclude that treatment of diabetes are to avoid acute decompensation, prevent or delay the appearance of late disease complication, decrease mortality, and ultimately to maintain a good quality of life. So with this, I would like to thank the audience for listening to this brief introduction on the management of type 2 diabetes, which is 90% in most as compared to other types of diabetes. So thank you to all audience, and I hope you are united for the Diabetes World Diabetic Day. Okay, thank you very much. That's all. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much. Waalaikumsalam warahmatullahi wabarakatuh. Not a brief, Professor, very comprehensive presentation about diabetes mellitus Professor gave us. Thank you very much. So I will resume the presentation of Professor. So As professors say, that increment of diabetes mellitus is 72% in the world, so it's quite terrifying number. And as professors say, that the most important thing was screening for the type 2 diabetes in all people more than 30 of age, including myself. Professor, thank you for the explanation.
Okay, most
All right.
welcome.
Professor, answer that. Yeah. Answer that there will be a lot of questions from the participants. Our discussion session will be held at 2.5 hours from now. So in 11:15 Indonesian time, with area of Indonesia to be precise. So we hope Professor willing to stay in the Zoom. Is that okay, Professor?
Yes, I will stay on. Thank you very much.
Okay, thank you very much.
Okay,
so,
welcome.
ladies and gentlemen, for the second speaker, we proceed to the second session today. So, in this section, the second speaker, we are proudly present Professor Dr. Anggraini Barlian, Master of Science. Hello, Professor.
Hello. Hello, good morning.
Hello. Yeah, good morning, Professor. Thank you to be here today with us. So before Professor Aang proceed with the lecture, first of all, let me read the CV of Professor Aang. Professor Aang was born in Bandung, 13 April 1963. He is a lecturer and professor in SITH, Sekolah Tinggi Ilmu Hayati, Institute of Technology Bandung. He has published many papers. I lost count on it, Professor, I'm sorry, related to the biology cell and developmental biology. The latest publication in a Google Scholar was in October 2023 with the title of The Properties of Exosome Derived from Mesenchymal Stem Cell Reconditioned with ascorbic acid and cobalt-2 chloride in Hayati Journal of Bioscience. And the citation number of the paper that Professor published was remarkable number. It is 768 citation. So outstanding, Professor. So today, Professor Aang will giving us lecture with the title of Regeneration Therapy for Diabetes Mellitus. I'm sorry. I will read the title, Regeneration Therapy for Diabetes Mellitus. Right, Mr. Professor?
Yes.
Yeah. All right, Professor, your time is 45 minutes to giving us the lecture. All right, ladies and gentlemen, and Professor Aang, the time is yours.
Okay, thank you very much, Anggraini. So we have the same name.
Same name.
Thank you very much, all audience, and let me share my slides. Yeah, anybody can see my slide clearly and my voice?
Clearly, Professor Aang.
Okay, thank you so much. So in this occasion, I would like to share a little bit also related to our research in ITB. This is about the regenerative therapy for the diabetes mellitus. So I'm from School of Life Science and Technology in Institute of Technology Bandung. So this is my outline of my speak. First, I will talk about the regenerative therapy and also the stem cell, and then a little bit the flashback about the stem cell, and also the next one about the exosome, and what is the regenerative therapy in the diabetes mellitus, and also a concluding remark. So when we are talking about the regenerative therapy, it's always related to the stem cell. So why is it? If we see the characteristic of the stem cell, or in Bahasa is cell punca, we know that the stem cells is a cells that undifferentiated, and it has the capability for the self-renewal, whether become undifferentiated stem cell still, or become differentiate to become a certain type of specialized cells. So because of this characteristic, the development of the research regarding the stem cell is very advancing. So if we are talking about the types of the stem cells, we can divide it by 3 different kind of stem cells. The first one is embryonic stem cell, which has the capacity pluripotent. It means that the embryonic stem cells can differentiate, become many different kind of cells. And then the second one is adult stem cells. We are more focused in our research with adult stem cells because the embryonic stem cell, we are facing the problem with the bioethics. And I don't think Indonesia allow us to use the embryonic stem cells, and also in many other countries. So adult stem cells is more applicable. However, the characteristic of the adult stem cells is multipotent. It means that adult stem cells can be generated, become different kind of certain cells. And we know that it depends on the source of the adult stem cell itself. So basically, the mostly used is mesenchymal stem cells, and also we have the neural stem cell, which is very limited, and also hematopoietic stem cells, because we also know that people can also use the bone marrow, for example, as a source of the hematopoietic stem cells. Usually can be used also as a source from adult stem cell, but taking the bone marrow, it is quite an invasive procedure. So what we're doing in ITB, in my lab, we used a lot of the mesenchymal stem cell come from the umbilical cord. And these mesenchymal stem cells can differentiate, become a chondrocyte, adipocyte, and also osteoblast. And in a certain condition, it also can be directed to differentiate, become a myoblast. And we know that the breakthrough about the stem cell research is when we found the reprogramming factors, as we name it, Yamanaka factors. And of course, we all know that Yamanaka get the Nobel Prize in 2012. What he did is from the differentiated cells, from the fibroblasts, from skin cells, his group can reprogram the cells that already specialized, become a pluripotent stem cell. That's why the result of his cells, we call it iPSC, or induced pluripotent stem cells. So this Professor Yamanaka from Kyoto University that was awarded a Nobel Prize in 2012 in physiology and medicine for his discovery of induced pluripotent stem cell. Professor Yamanaka, and also the reprogramming factors, we call it Yamanaka factors. He now is working in Center for iPS Cell Research and Application in Kyoto University, or CYRA. So many kind of disease can be cured actually by these iPS, because the patient-specific iPS cells can be used to replicate the human pathological conditions. By using the patient iPS cells, the CYRA researcher now is investigating disease mechanism to discover new drug candidates. So here we can see that regarding the iPSC, this is one of the life science frontier where the iPS cell technology can change the cell fate without genome editing. The CYRA researchers also use the iPS cells to study the mechanism of many different kinds of cell development, and also try to elucidate the key factors in determining the cell fate. And we can here see all the words in the red box. This is the one that they're already doing the research with using the iPS cells. that's why, because of this advancement in stem cell research, and especially with this Nobel Prize from Yamanaka team in 2012, then we now know the terminology of regenerative medicine. And what is the regenerative medicine actually? What is the concept? So we know that diseases develop due to a loss of many malfunctions of the cell in the body. And Sarah researcher also working in the development of regenerative therapy for various disease to recover all the cell function by replacing the dysfunctional cells with iPS cell derived cells. So including here is pancreas, which is, we know that the problem with the damage of the beta cells can lead to the diabetes. So we know this is also in nowadays that the research team of Yamanaka team, they also advancing, including using the new system, using the biotechnology and also artificial intelligence, and looking for also novel coronavirus because we had just finished or passed the pandemic, and also intercellular communication. And this will relate it to the exosome that I'm going to talk about later, and genome editing, reprogramming the stem cell, and animal derived iPS cell. And of course, when we are using the stem cell, we are doing it in vitro. And also we are facing the bioethic regulation. And that's why using the embryo stem cell, especially human embryo stem cell, is not a choice. So that's why I think the invention of this iPSC, induced pluripotent stem cell by Yamanaka team, this is really a breakthrough. So we can have the cells that equivalent to the embryonic stem cell, which is a pluripotent. So that's why I think this innovation or invention by Yamanaka team become very, very popular nowadays in the world. So I will tell a little bit about the stem cell itself. So as I mentioned before, that stem cell is undifferentiated cells or unspecialized cells. And it has a capability for self-renewal. It means they can make their own clone, make more stem cell. So the stem cell pool will be always maintained in the body. And of course, this is also related to the age. And then also the stem cell with the inducement of many kind of the transcription of factors, it can differentiate, become many different kind of cells. So far the potential use of the stem cell basically as a cell source for tissue engineering. It means that the stem cell itself become a product and can be used as a new cell source to replace the damaged cells in our body. So this can be used in tissue engineering. And also for disease modeling, for drug testing, and the last one is for alternative therapy, including for diabetes mellitus. Our lab, we use the mesenchymal stem cell because we think that the mesenchymal stem cell, especially from umbilical cord, and we get it from the wart jelly stem cell or HWG. This have advantages over another type of mesenchymal stem cell. Of course, bone marrow, also the mesenchymal stem cell. But to get the bone marrow, human bone marrow, it is very difficult, and also the procedure is invasive procedure. But this wart and jelly stem cell, mesenchymal stem cell from umbilical cord, it is left over from the giving the birth, so it is more applicable for our research, and also can be a source that quite a lot in Indonesia. And mesenchymal stem cell is a multipotent stem cell. And as I mentioned before, the isolation, we just have a collaboration with the hospital. And this is a very not non-invasive because this is a leftover. And also the human Wharton jelly also has a higher proliferation rate and also wider plasticity compared to other source of the stem cell. And also this can be used as an allogenic source because the immunorepressive of the Wharton jelly mesenchymal stem cell. So it is beneficial to use the mesenchymal stem cell from human Wharton jelly. And the next one is exosome. What is exosome actually? Exosome is extracellular vesicle that are produced by the cells, including stem cell, of course, with the size of 30 to 100 nanometers, sometime in some literature, 30 to 150 nanometers, which function in the cell communication. So as we can see here in the figures, the diagram, so this is the exosome with the structure of a vesicle, so spherical structure. And we can see consists of lipid bilayer. And in the lipid bilayers, there are some proteins, protein membranes, and that protein membranes can be used as a marker whether we are getting the exosome or not. And the most important thing from the exosome, the most interesting one, is the cargo. The content of the exosome. As we can see here, there's a mRNA and also microRNA and also actually long non-coding RNA, many bioactive compounds, proteins such as interleukins. So this is all the cargo or the content of the exosome. So in our lab, we already isolated and characterized the exosome from human Wharton jelly. And as we can see, this is the 10 image. You can see also from the picture is a lipid bilayer. So this is the exosome we isolated and characterized with the certain CD marker and also morphologically with the TEM, transmission electron microscope, as we can see here. And also we measure with PSA the size of this exosome. So this exosome actually is not only a stem cell secret or produce the exosome, but why is it so important now? Because actually in stem cell use, now it's divided, become cell-based therapy and cell-free based therapy. Cell-based therapy, it means we use the stem cell itself as a product to replace a damaged cells in a certain tissue. For example, if we have a problem with the pancreas and we want to replace the beta cells in the islet of Langerhans, so long time ago, the people already put the stem cells inside the pancreas. So that is the cell-based therapy. But nowadays, when we know about the exosome, so we have the exosome produced by the stem cell, which is we believe that the exosome from stem cell, or we call it stem cell derived exosome, actually have the same, exactly the same capability and capacity with the stem cell itself, because the exosome function in the cell communication. So this exosome era is become a cell-free based therapy. And people more prefer the cell-free based therapy because some of the researchers also afraid if the cells, the stem cell of the cell from the stem cell can also not going directly to the organ that will be replaced. Some of the cell will be replaced, but the problem is also it is tumorogenic. It has a very high activity in cell division as a main or base characters of the stem cell itself. So we can see here the cell-based therapy compared to the cell-free based therapy. Cell-based therapy usually be used for cell transplantation, but instead of the cells, we can use the exosome come from the stem cell as a stem cell product. And the stem cell used for the transplantation usually will be autologous, suggested autologous, so that will be not immunogenic. Or if the source is impossible, then we can use other source as allogenic, but we have to choose the less immunogenic one. And one of them is the human water jelly mesenchymal stem cell is one of the choice of the stem cell that has less immunogenic. But using the exosome in cell-free base therapy is non-immunogenic. Okay. And so the use can be allograft in a certain case for cell-based therapy, but should be very careful, and we should check the major histocompatibility complex first, 1 and 2, graft. But in a certain case, when the patient probably is old enough and the function of the organs, the damaged organ is not good anymore, so there is no choice to use the autograft. But for the cell-free base therapy, it is not autograft, allograft, or even xenograft, but we can use the exosome with many different kind of the sources. So the exosome itself actually does not only come from the stem cell, but the exosome also can produce by any kind of the cells, including cells in cell culture. And in our blood, we have so many exosomes. Also in milk, there are so many exosomes in urine and also in saliva. And one of my colleague using urine and try to find the exosome to determine for the pre-diabetic stage of a patient. As Professor Sarina mentioned before, the pre-diabetic observation is very important because it's before it getting too late with a more severe diabetes. So this using the exosome in urine, which can be detected as a pre-diabetic. For pre-diabetic, it is a very good advancement in research of related to the diabetes and exosome. So the exosome, of course, because it is produced by the cells, exosome determined by the cells that produce the exosome itself. And as I mentioned before, that therapeutic ability of the exosome from the stem cell equals to the ability of the stem cell itself. That's why nowadays the research of cell-free base therapy using the exosome, especially from the stem cell, is very, very advancing. So let us see what is the difference now between the stem cell, the secretome, and exosome. What I know, especially in Indonesia, mostly the research is in the secretome, because the culturing of the stem cell, we have to do it in vitro, of course, in the flask. So the stem cell source can be autologous or from the donor. And the cells produce many, many things, including the exosome and many, many other vesicles to the medium. So it can be collected, and that's why we call it a secretome, secreted by the cells. So secretomes contains many different kind of proteins, growth factors, cytokine, and also extracellular vesicles. But when we are talking about the exosome, we have to isolate again from the secretome to get the exosome. This exosome is one of the extracellular vesicles, and we can see next here, this is actually exosome and the extracellular vesicles. When we talk about the extracellular vesicles, we talk about the size and also about the biogenesis. So if we can see exosome here in this figure in the left side, so the size is around 30 to 100 nanometers, or sometimes 30 to 150 nanometers. And the origin of the exosome, as we can see in the diagram, in the picture, this is through the formation of multicellular vesicular bodies. But more general, microvesicle or ectosome has a little bit bigger size. It's 100 to 500 nanometers. And the process or the biogenesis is a bit different compared to the exosome. This is from budding from the cell membrane. And of course, there are many other vesicular vesicles which has a very small size. Could be apoptotic bodies. These apoptotic bodies, the size can be from 1 to 5,000 nanometers. So the range is very big, very huge. So this, of course, the formation is through the apoptotic bodies. So when we are talking the extracellular vesicles, this is many different kind actually. But exosome, when we call it exosome, this is because the biogenesis. So we can see here the exosome biogenesis. So the exosome biogenesis, here we can see that from the late endosome, all the proteins, RNA, including microRNA, messenger RNA, DNA, long non-coding RNA, this can be integrated to the late endosome. And this late endosome become bigger, and we call it late multivesicular bodies or MVB. And this MVB, the fate can be either degraded through the formation of the autophagosome and join with the lysosome, or exocytosized outside the cells, or in this case we call the cell secrete the exosome into the extracellular cells. So here we are talking about the exosome, and this exosome is the biogenesis of the exosome is different compared to the other vesicular vesicle. So in our research in our lab, we are starting to isolate, characterize, and do some experiment with the exosome. And this is toward the transform from the cell-based therapy to the cell-free based therapy, as we can see in two of our review article. The last one in this year, we are working together with the dentistry from Gajah Mada University. So we can see here that the content or the cargo of the exosome that produced by the living cells, it is very important and has a very high potency in regenerative therapy. And we can call it the extracellular vesicle because exosome is part of the extracellular vesicle, unless the size is quite limited, and also the biogenesis is a bit different. So, and the exosome in our lab also can be used for the tissue engineering. And here we can see, of course, this is in the future that the isosome isolated from the human mesenchyma wharton jelly, and we can increase the secretion of the exosome by many ways. For example, we can culture the cells of the human wharton jelly mesenchymal stem cell in or under the hypoxic condition, like 1 to 2% to 5%, the most of oxygen level, and it will induce the cells to produce more and more exosome. Or in my case, I use also the chemical pretreatment medium, such as the hydrogen peroxide, mechanical stimuli, and also with the genetic engineering. And actually, the exosome also can be modified post-secretion by a surface modification and also cargo modification. So overall, the exosome also can be used as a delivery vehicle, yeah, of course, engineered as a signaling molecules. So in other paper, it mentioned that exosome isolated from the patient can be manipulated outside the body, of course, in vitro, and even can be loaded by therapeutic drug, including we can load the microRNA, small molecule drug, yeah, which is, of course, here is FDA or BP-POM approval drug. and also we can add some peptides and antibody, and also some tumor targeting ligands. So this delivery vehicle will be a targeted one. And actually nowadays we can only buy the microRNA. It's just like a primer, very short. And so we can have the synthetic microRNA, because the research regarding the microRNA from exosome nowadays, there's so many, so plenty. And we can just order the microRNA related to, for example, in diabetes disease. Yeah. So whether it's microRNA 121, for example, that related to the inflammation, then it can be put inside the exosome. And because the exosome is a lipid bilayer, it is very easy, and a small size, it is very easy to be integrated and endocytosized by the cells in our body. So now we are talking about the regenerative regenerative therapy in diabetes mellitus. So as you can see here, perhaps the most advanced one is the regenerative for the cardiovascular therapies. Why? Because I think the cardiovascular is the most #1 leading disease in the world. That's why the research about this regenerative cardiovascular therapies is so in the forefront. How about the diabetes mellitus? But I think the revolution about this is almost the same with the cardiovascular therapies. We can see here in the figures with the center picture of the heart, of our heart. So we can divide it. The first generation of the cell therapy here is using the stem cell, and we can see it for the first generation of cell therapy using the stem cell. There's so many different kind of stem cell has been used and researched for the cardiovascular therapy. We can see here from the mesenchymal stem cell, hematopoietic stem cell, bone marrow stem cell, epithelial, and smooth muscle stem cell. There are so many different source of stem cell. And for the second generation of the stem cell cell therapy, then we can see this is starting using the iPSC, or induced pluripotent stem cell. Yeah. And I think this is the next generation of the cell therapy for the cardiovascular and also for the diabetes mellitus. Then we are using the patch, which is from the cell sheets, and also many different kind of RNA, such as microRNA, mRNA, or long non-coding mRNA, and also exosome, which is we can see in the figure. All those kind of the factors or molecules can be integrated in the exosome, and many factors too. So this is the next generation of the cell therapy. And here is, I give the example, the most established one with the cardiovascular regenerative therapy. If we can see in the left side, this is the cell-based therapy. How the cell-based therapy advancing and become can be used as the therapeutic outcomes in the cardiovascular disease. And we can use, we can see also the cell-free therapy, which is, we can see not as many as the cell-based therapy, because the cell-free based therapy, especially using the exosome, is not too long ago, perhaps 7 or 8 years lately. So here we can see we already can see that the use of many different kind of origin for the cells, origin of the stem cell, including the last one is iPS, the pluripotent stem cell, and then transplanted to the site where the damaged area, the most damaged area in the heart. Okay, so here we can see there are many different kind cell types that already transplanted to the heart in the damaged place. And the mode of delivery also many different kind ways, like using the cell suspension. But the thing is, when we do the cell-based therapy, that will be invasive procedure, because that, as we can see here, intramyocardial, intracoronary, intravenous. Well, intravenous probably the less most invasive one. But for intramyocardial and intracoronary, then we have to have a surgery to put the cell suspension. And it can be used also the cells that embedded into the matrix or cell sheets or human engineered heart tissue and put directly in the place where the myocardial infarction, where the place of the damaged heart cells area. Okay, so this is already proven that can increase the left ventricular ejection fraction, also increase the upstroke velocity, increase the vascularization, and also decrease the fibrosis and scar formation. So the cell-free base therapy, it is not too many because it's still ongoing. But you can see here, cardioprotective exosomes now is coming using a certain cargo, certain content of the exosome that will be delivered. Of course, easier compared to the cells-based therapy because exosome you can use just the intravenous. Okay, and it will deliver to the place specifically. Why? Because as we know that it is also has the homing capability. So now we are focused to cell-based therapy for diabetes mellitus, and after that we are looking at the cell-free based therapy. So as I mentioned before, this is I take from the internet, and actually this is very shocking because there's so many information come from the company that over how to overcome the diabetes mellitus by the stem cell therapy. Here we can see how the stem cell help the diabetes, for example, even for type 1 diabetes or type 2 diabetes. Okay, and it is originally from the patient itself. So this is autologous. We can get it from the liposuction. We can get from the adipocyte stem cell. So the extraction from of the stem cell. And of course, we have to do it in vitro by enriching them in the lab, propagation, and get some more clean or isolated only the cells that we want, and then do the reprogramming and inducing the pluripotency. Then after that, we can also differentiate into the beta cells only. And after we get the beta cells pool, we can do the transplantation. Yeah, but this is very invasive because it should go to the pancreas directly. And also actually in the right side, we can see this, we call it one of the company before. In the left side is Medical Tourism Corporation, and this is Funducia. This is other company, and you can see here they mention about having the bionic pancreas. And the bionic pancreas, we can use the 3D printing, so we call it the bioprinting, and put the cells there, and of course, the cells producing insulin and also glucagon, and this can be then transplanted back to the patient. Okay, and of course, there should be a storage for the evaluation and safety and functionality. So the other thing that I come across in the article, how the age-related adipose tissue dysfunction, this is very much related also to the diabetes. This also because the age-related adipose tissue dysfunction drives the metabolic and functional declines, leading to the chronic disease and frailty. And actually, this age-related adipose tissue dysfunction also leads to adipose redistribution, local and systemic insulin resistance. This is type 2 diabetes, and also chronic sterile inflammation. So from here, we can see that without any intervention, this can induce systematic metabolic dysregulation and also functional decline, and eventually leading to diabetes and frailty. So here we can see that the adipose tissue dysfunction can lead to the diabetes, and here we can see how this the adipose tissue dysfunction also at the same time you can use as a source for the stem cells, and manipulate it outside the body and put it back to the patient. And I show you in the last slide. In Indonesia, we have also the clinic who do that such a thing. So based on the adipose tissue dysfunction and related to the insulin resistant and diabetes here, this we can see the synergistic effects of adipose tissue dysfunction and also cellular senescence and pro-inflammatory state that lead to this decline in physical function and frailty. So the other thing that's the possible mechanism of the stem cell in the type 1 diabetes. We can see here that the stem cell were used in the reconstitution of the immunotolerance through the activating 3 regulatory cells here, Treg, and inhibiting the T and T helper 1 cells. And here we can see this also can be used for the preservation and regeneration of the beta cells, as we can see in this figure. So as I mentioned before, that the stem cells has the homing ability and homing and migration. This very specific characteristic from the cells, from the stem cells. So actually, if we inject the stem cell, it will migrate through the blood vessel. And it has the homing ability. It will go to the place that the inflammatory occur in a certain organs. Okay, but however, some of the research showed that the stem cell also can migrate missed to the missed place, and people afraid that it can be a tumor in other place. So that's why the exosome choice or cell-free based therapy choice, I think it's a better now. So this is the cell-free based therapy for diabetes mellitus. So as we know that it can be pancreatic islet beta cells damage or insulin resistance, and can cause the hyperglycemia and many other diabetes complication can occur. But on the right side, we can see that if we have the mesenchymal stem cell, so the mesenchymal stem cell, we can produce or we can have the exosome from the mesenchymal stem cell, and we know the exosome in the vesicle, in the lipid bilayer vesicle, it has many different kind of growth factors and also anti-inflammatory cytokines and also other therapeutic non-coding RNA. In our lab, we already have the result about the anti-inflammatory cytokines produced by the exosome and also non-coding microRNA in the exosome. So this exosome, actually, we hope that can have the repair mechanism. Why? Because the exosome play a role in the cell communication. So it can regulate the inflammation, vascularization, and also podocyte repair. This is in the case of the kidney failure, and also improving the renal fibrosis, multiple tissue regeneration, including the pancreas for the diabetes. So I'll show you some of the papers regarding the research about the using of the stem cells for diabetes mellitus, or we can call it the regenerative therapy, because regenerative therapy means that your healthy cells will be induced by the stem cells or the product of the stem cell that has many regulatory factors and also growth factors to induce, to make the cells, the healthy one, to regenerate, to make a new healthy cells. I think that is the concept of the regenerative therapy. So as we can see here, this is from the Nature Milestone, the diabetes 2 years ago. And it has a very nice paper here with the title Towards a Stem Cell Therapy for Diabetes. So here we can see that I put in the box the red one. You can see also by yourself this paper. But in general, in this paper, we can see that from 2015, 2019, 2022, and so on, there are so many advancing research using how to use the stem cell for the therapy for the diabetes. Okay, so I think people can also make beta cells, human beta cells from human pluripotent stem cell. Of course, with the finding of the Yamanaka 2012, this become a very good point to have a diabetes therapy from the stem cell. And also nowadays we can see that the many other way or procedure how to make the beta cells, okay, especially from pluripotent stem cell. And I'll show you this is how easy we can see as an advertisement of using the stem cell therapy from the for diabetes. You can see here how the stem cell therapy can help you. So it depends on the country. For example, for us in Indonesia, we can see here the price is average 15,000 US dollar for stem cell therapy from the diabetes, and also in Europe, in Latin America. But this is very commercial. And also, I'll show you the other one. This is stem cell therapy for type 2 diabetes treatment, stem cell therapy, and so on. This is from GARM clinic, and they offering, this is in Caribbean island. Yeah, they're offering how the stem cell therapy for type 2 diabetes in this clinic in Caribbean island. So there are many in other country. And in Indonesia, I show you one. Here, this is a stem cell kendalikan gula darah and komplikasi diabetes. So this is in Bahasa Indonesia. As we can see here, you can see in the right side, there is a Clinic Hyandra. That Clinic Hyandra in Jakarta also, they have approved, they have some papers too. And they can show that if we can do the liposuction and process the mesenchymal stem cell from the liposuction from the adipocyte, and then make it in vitro, manipulate a little bit, yeah, and you can have a storage and put it back by IV to the person body. So it depends on how many adipocyte cells you can get, and it can be treated like 3 times to 4 times, yeah, from your own stem cells. So this is already quite well known in Jakarta. So my last slide, this is a concluding remark. So we can see that regenerative therapy is quite promising and also bring hope for the future wellness and also healthcare. As we can see, perhaps the one with the cardiovascular is already proven, and also including for the diabetes mellitus, as we can see so many advertisements using the stem cell therapy for the diabetes mellitus. And the new trend using the exosome. This is a new exosome is a new trend in regenerative therapy, and I think it's become powerful tools in the regenerative medicine overall, not only for diabetes mellitus, but for many other diseases. Okay, especially I think with the degenerative disease. Okay, but to get the exosome, it's quite difficult and expensive. Yeah, even compared to the stem cell itself. So the development of technology, knowledge, and ethical regulation is very crucial in the sustainability and development of the future regenerative therapy, especially for the diabetes mellitus. I think that's all for my presentation. Thank you very much for listening. Thank you.
Thank you very much, Professor Aang. So a very clear, insightful, and advanced lecture Professor gave us. So thank you very much. Here I'm struggling with making a review of it because the advanced technology that Professor gave. So Professor explained about the basic of the stem cell, the first like exosome, the new trend of degenerative therapy. It's so inspiring. We need to keep keep up, or we need to reach that technology to in Polkesban. So thank you very much, Professor.
You're welcome.
Professor, we will have discussion session at 11:15, Professor, and please willing to wait and in the Zoom until the session. Is it okay for Professor Aang?
Okay, no problem.
Okay.
Yeah.
Thank you very much, Professor. Okay, ladies and gentlemen, thank you for still be with us in this virtual event. So, for the third speaker, we are very proud to have Mr. Ridwan from Health Promotion Department, Poltekkes Kemenkes Bandung. Mr. Ridwan will present about the practical implementation of health belief models to improve health behavior outcomes in DM patients. Mr. Ridwan, good afternoon.
Good afternoon.
Mr. Ridwan Setiawan was born in April 7, 1967. He has Bachelor of Nursing from University Pajajaran Bandung in 1997 and a Magister at Public Health from Health Promotion University Gadjah Mada Yogyakarta in 2003. Mr. Ridwan until now is a lecturer in Polytechnic Health of Bandung and serves as head of department from 2018 until now in Health Promotion Department Poltekkes Kemenkes Bandung. Mr. Ridwan, 45 minutes from now, and the time is yours.
Thank you, moderator. Good morning, ladies and gentlemen. I am Ridwan Setiawan from Health Polytechnic of Bandung, presented practical implementation of health belief model to improve health behavior outcome in DM patient. Both topic moderate activity exercise and blood sugar control. Next slide for introduction. Yeah. WHO Global Plan 2018 until 2030 aim to prevent and treat non-communicable disease NCDs like heart disease, stroke, diabetes, and cancer to physical activity, target preventing diabetes mellitus overweight on obesity while improving mental health and overall well-being. Diabetes prevalent in Indonesia. Indonesia faces a rising trend in diabetes prevalence from 6.9 to 8.5. City-specific data from Bandung indicated 43,906 people diagnosed with diabetes. Risk factors such as obesity, central obesity, smoking, lack of physical activity, and low fruit vegetable intake are increasing. Health impact and economic burden. Diabetes significantly impact human resources quality, escalate health costs. High variety from prevention and treatment due to its widespread effect on health and well-being. Next slide. Health belief model component. We have 6 components. 1, perceive the sustainability. 2, perceive severity. 3, perceive benefit. And 6, safe application. Is topic a safe application. Okay. Next slide. Please, next slide. We have 4 pillars of diabetes control. 1 pillar, education. 2 pillar, adjustment. 3 pillar, regular accessories, regular exercise. And 4 filler medication adhesion. Yeah. We have preset filler of diabetes control, research on physical activity and diabetes. Studies show that physical activity positively influence blood sugar hyper in type 2 diabetes patient, accessory on clinical benefits such as increases insulin sensitivities, reduce glycated hemoglobin spike. Next. Sample regular exercise. Yeah, we have 30-minute regular exercise video. Yeah. Example, step 1, walk with your hand and your hip. Next, lift on leg alternative behind you. Yeah. 3, catch your breath on swing both hands. It's all video 30 minutes. Next slide. This is research moderate activity in patient diabetes. Yeah. Method, we have research design, quasi experiment, pre-post test within control group design. 2, research population and sample. Population at is 60 participants, 30 in each group, 60 participants, and variable, dependent variable, blood sugar, test result, independent, and independent variable, moderate activity exercise. The set intervention, moderate activity conduct 3 to 5 days a week, pro 30 minutes each day through moderate accessories video. Instrument use, blood sugar test conducted and due beginning and off to study. Yeah. Research intervention focused on value at 0.05 significant, with different blood sugar level before and after treatment. Next slide. Result table 1 about responding characteristic. Yeah. We have 2 group, 1 group age and gender. Age 50 until 55, 56 until 60, 61 until 65, 65 until 70. And gender, male and female. Male, about we have 2, and female 20 eggs. It's intervention group and control group. Amount 8, 6, 2, 10, and 12. Control group 7, 3, 9, 11, and control group gender male 7 and female gender 23. Next slide. Table 2, average initial and final blood sugar type 2 diabetes patient. We have pre-blood gas analytic and final blood gas analytic. We have 95% confident interval to group 1 to intervensi and group 2 adalah about control. Ya. 95% confident interval for intervensi 3.191 until 7.609. For control, we have 95% confident interval 2.183 until 10.084. P-value for pre blood gas test we have 0.00 and final blood gas test 0.004. Next. Table 3, mean blood sugar intervention in control group of type 2 diabetes patient. We have two group, one group intervention and another group control. We have related standard deviation as a mean, as a different, and final we have p-value 0.038. Next. We have a discussion, study results, so that average blood sugar level in type 2 diabetes patient exhibited and significant difference with moderate activity accessories. We have p-value 0.038. This suggests a positive impact on blood sugar control in type 2 diabetes patient at Bandung City Health Center. Next slide. Physical activity recommendation, type 2 diabetes patient or advised to engage in physical activity 3 until 4 times a week for 30 minutes to optimize blood sugar control. High physical activity lead to increased endogenous glucose, promoting a balanced blood sugar level. Aerobic exercise for diabetes management. Aerobic physical exercise is prepared for diabetes management, considering factors like as socioeconomic condition and BMI, attention to potential hazard and food call is crucial due to high infection rate in diabetes people. Infection rate diabetes people. Next slide. Benefit of moderate activity exercise. Moderate activity exercise affordable and lasting approximately 1 hour is ideal for senior, overweight individual, pregnant women, and those with diabetes mellitus. Regular physical activity reduce HbA1c. Supportive by resource showing a description and HbA1 by 0.66 until 0.8. Supporting evidence, aerobic fitness has a protective effect on cardiovascular disease or CVD, mortality, and diabetes prevalence independent of BMI. Studies indicate positive effect and aerobic exercise on blood glucose level in various populations. Next. Conclusion, there is a significant difference in blood sugar measurement result, which means that there is an influence. Moderate activity training in type 2 diabetes. Next. Thank you. In wrapping up, let's embrace the positive impact of support for those with diabetes. As we finish our discussion, may this insight inspire in commitment to healthier lifestyle, bridging the gap between exercise and diabetes management for a brighter future. Thank you, everyone. Thank you, moderator.
Thank you, Ridwan. Very inspiring presentation. All right. Now we reach the discussion segment. So once more, we'll welcome Professor Zarina and Professor Aang. Please committee to spotlight Professor Zarina and Professor Aang. Professor Zarina.
Yes, I'm here.
Okay, thank you, Professor. Here we have some questions for all the speakers. Let me share the first question from Ibu Ida Farida to Professor Zarina Awang. Please kindly elaborate on the therapeutic lifestyle changes that should be instituted for clients with diabetes mellitus. All right,
Well,
for Professor Zarina, please.
Okay, thank you, Dr. Angretti. So these questions, I think, sort of overlaps with the third speaker. Okay, lifestyle changes. So for I think lifestyle changes involve the daily activity, the kind of job that the person is engaged with. As you can see, that our lifestyle has been sedentary, for the past few decades. A lot of job is non-agricultural, especially in the city, urban area. So one of the thing is education. It should start at all level, including the school, because obesity is noticed even in the children at this age because of the fast food. So I think dietary, and then the choice of food must be conveyed during as part of the medical education in early childhood, as well as along secondary school, even at the university levels. And for the government, the most important is to control this kind of food. And then we should encourage high fiber diet, fruit, fishes, and things like that. Because I noticed that McDonald influence is very high in Malaysia. And these are the lifestyle diet that is being seen, especially in the younger age group. As for the elderly, I think it has something to do with the sedentary lifestyle. Exercises need to be incorporated in our lifestyle. So any agency, I think what you need to do is to have a time for the staff to have exercises program. It need to be implemented in the daily routine, not just job specific activities. So that's all that I can say for this. Thank you for asking this question. So probably the other panels can also add on to this.
Okay, thank you very much, Professor Zarina. I also like Mr. Ridwan maybe giving the explanation also about this. Mr. Ridwan, you also can answer in Indonesia. because the most of the participants are Indonesian.
Yes, yes, yes.
So, Mr. Ridwan, menurut Bapak untuk perubahan lifestyle yang harus dilakukan untuk menghindari atau untuk treatment juga, first treatment untuk pasien yang sudah didiagnosa diabetes mellitus itu seperti apa, Mr. Ridwan? Mohon penjelasannya, terima kasih.
Maybe research we have kondisi fit, ya, and supervisi under supervisi in professional patient diabetes, please do activity normal with video 30 minutes, ya, under supervisi profesional.
Okay, so memberikan pengertian or help promotion to the patient or all the people about the importance of the lifestyle to combat or to treat the diabetes mellitus is very important. Yes, Mr. Ridwan, thank you for the explanation. Also to Professor Zarina. All right, we will proceed to the second question for Professor Aang. The question is from Ibu Widya Stiwi, the chairman of this seminar. So regarding the safety of the regenerative therapy, is there any potential side effect of regenerative therapy compared to classical therapy? Please, Professor Aang.
Okay. Thank you very much, Ibu Widi, for the questions. Yeah, actually, for the safety itself, for the regenerative therapy in general, so far, it's positive result. However, in some of the cell-based therapy, some, but not too many, they mention that the stem cell that is not go to the appropriate place or target place of the organs in our body, then it become a tumor. And also, I think in animal model also, some of the research show that tumorigenicity of the stem cell. That's why I think nowadays they prefer to have the cell-free based therapy because it's much safer in terms of the immunorejection. There is no immunorejection because exosome is not the cell. Exosome is vesicle with the shape of the spherical with the lipid bilayer. So it is not the cell. So it will not cause the response of the body. Okay, but as I mentioned before, that to get the exosome, we get it from the secretome. So it's the procedure to get the exosome to isolate, and then we make sure that it is an exosome. It's quite time consuming and also expensive. So small amount, small volume, but with the much higher potential than using the cell-based therapy. So I think the safety actually for the stem cell, for the cell-based therapy and cell-free based therapy so far is positive. It means that more good result, more positive result compared to the negative result, or you say probably side effect. Side effect, so far, it is not reported yet, unless the mismigration, misplaced of the cell base therapy and become a bunch of undifferentiated cells or become a tumor. Okay, so but I think in my point of view, because the cargo or the content of the exosome, if we are talking about the cell-free base therapy, even though it is the safest one, but I think all the growth factors is there, all the microRNA is there, many different kinds, hundreds or even thousands inside the exosome. Of course, there is some the antagonistic antagonistic effect and also probably synergistic effect. So since this exosome research is still going, we don't really know whether more the good factors that we can get from the exosome or also the bad factors. Okay, but so far using the exosome, still many or more positive result, because we cannot choose which exosome. We cannot choose because all the cargo in the exosome, many thousand, we cannot choose. That's the problem with the cell-free base therapy or exosome. I think that's what I can answer for Ibu Widi. Hopefully I can answer your questions. Thank you.
Thank you. Really, Ibu Widi. So give
Thank you very much, Bu Aang. I call her Bu Aang because she's my lecturer from my bachelor degree. Mrs. Aang, I also want to ask about the development of cell-based therapy and exosome therapy is still in the development process in vivo or are in the clinical trials, or how much the development process is in this moment.
Okay, so if we are talking about in the world, of course, the most advanced using the cell-based therapy and also cell-free based therapy is Japan. Yeah, because I think based on the Nobel Prize from the Yamanaka from Kyoto University, so the advancement is very fast, especially after 2012. Yeah. So the Japan government, even they can like our like BPJS, yeah, their social card, they can also cover the use of the stem cell. That's what I heard from one of the professor that just visit us last month. He said that the patient just only have to pay like 3%. 3% is very low, yeah. But we know that the therapy using the stem cell, which is the regenerative therapy, it's expensive. So it's a kind of limited now. I hope when the techniques or this advancement is getting faster, then the cost can be down. As I can say that in Indonesia, for example, Stem Cell and Cancer Institute from Kalbe, they have transgenic, right? Transgenic, the stem cell they sell, and one cell is 1 rupiah, but we need 100 millions of cells. It is impossible we just use 1,000 cells. It's very little in terms of cell number. So we need probably 100 millions, or sometimes if the damage is so big, then it can be up to 500 million to 1 billion. So it means that in terms of money, that can be 500 juta rupiah or 1 million rupiah. So that is quite expensive right now. So it is still limited in our country. But as I showed you in my slide, some of the clinic, they already have a license and can use as long as autologous. They get it from their own patient stem cell and manipulate outside, of course, in vitro, and put it back. Yeah, put it back for the patient. I heard once you get the liposuction and put all your stem cell in their clinic, minimum is 120 million rupiah. Yeah, and then but I think the result, if we can see from their articles is promising and all positive result, even though quite usually above 60, yeah, and they also grow hair and nicer skin, something like that, because there's so many growth factors in the exosome and also in the stem cell. So I think that's what I can answer for Widi. Hopefully, I can answer your questions.
Thank you very much, Mrs. Aang.
Right, very impressive the explanation. So we will proceed to the third question. The third question is from Ibu Fauzia. Ibu Fauzia also dedicated the question to Professor Aang. Is HbA1c examination, oh, I'm sorry, it's supposed to be for Professor Zarina, I'm sorry.
Yeah, I think so.
Is HbA1c examination used as a screening test in Malaysia for all the DM patients?
If the question is regarding diabetic patients, meaning that the person has been acknowledged to have diabetes, so we use HbA1c for monitoring. Okay, monitoring. And at the first level of diabetes, we use two parameters that is based on the OGTT, okay, the fasting as well as 2 hours postprandial. If it is raised, okay, repeat again for the second time, and then tie up with the HbA1c. If the HbA1c, then you can categorize the patient based on the severity of the diabetes, whether it is mild, moderate, or severe. But the diagnosis of diabetes itself is based on the GTT test, the fasting as well as the postprandial test.
Okay, very clear explanation. Maybe Ibu Fauzia want to ask more about this, Ibu Fauzia? All right. I think it is a clear
Okay,
explanation.
thank you, Prof.
Welcome.
Yeah. All right. It is the end of the question, but I want to explore more about the stem cell or exosome. I want to ask some question for Professor Aang. So, Professor, what is the characteristic of the exosome? Because as we see in the slide that the outer characteristic of the exosome is the lipid in the bilayer. So in lab we use we create or we develop a liposome which we made it from phospholipid like phosphatidylcholine that has the same outer characteristic with the exosome. Is it maybe have the same characteristic? But the differentiation is the exosome is endogen, but the liposome is drug delivery that is not from the endogen like that. Professor Aang, can you explain about the different maybe and the characteristic of exosome itself?
Yeah. Okay. So basically, the characteristic of the lipid bilayer between liposome and exosome the same. Yeah, the same. But the difference is in the size, I think, in the size. And more specifically, because we know, especially if we just buy the lysosome commercially, it is only lipid bilayer. But if we take it from our cells, it also have the protein membrane in the lipid bilayer. And for the exosome, there are 4 types of the protein membrane that very specific for the exosome. We call it tetraspanin. So that's why if we isolate the exosome and we want to make sure that it is exosome, not other else, so it should be positive for CD63, CD9, CD81. At least those 3 should be present in the layer of the lipid layer. Yeah, so that is the difference. And lysosome, lysosome, I think it's empty. Yeah, but for exosome, it has so many cargo because the biogenesis, because it is produced, it is processed and secreted by the cells. So different with the liposome. Liposome is more human-made. Yeah. But I tell you that in our lab, one of the research of the PhD student, she got the exosome from jinten, black jinten, and then isolated and using the exosome as a drug delivery for cancer, and put the microRNA, a certain microRNA that is known that can cause the apoptosis and also inhibit the cell proliferation. So you put it in the exosome from black jinten, and then use as a delivery vehicle for the cancer treatment. That's what we did in our lab. Yeah.
Okay. How about the pH stability and maybe thermal stability of the exosome that we put outside, manipulated in vitro, Professor?
So that's the thing that we haven't explored much, because stability, we can only measure size with PSA, and then also we do the zeta potential, so we know whether it is stable or not. And the one that using the black jinten, she tried to lyophilize, so that will be more stable in a dry condition. Not in the liquid, because in the liquid you don't know what happened, because one of exosome and the other exosome can join together and become very big, and it is not good to enter the cells. So make it lyophilized. I think lyophilized is more appropriate to put in the stable condition.
Okay, thank you very much for the explanation, Professor.
Very welcome.
Mr. Ridwan. Mr. Ridwan, what do you think? What do you think the latest health promotion that we have to use, or we have to give to the patient, or to all the people right now, to minimize the DM or the prevalence of DM?
Thank you. Maybe application for pilot about education, dietary, exercise, and medication adherence is good philosophy, and have convenience patient, we can use personal approach. There is a few things that we can do. One, about counseling. Two, supervision accompanying. Three, under expert supervision. And then for train independently in routine. It's Mr. Thank you, moderator.
Okay, thank you very much, Mr. Ridwan. And we have questions in the chat room here from Mr. Yusuf Liongo to Professor Zarina. I would like to ask about the lifestyle behavior. Is there evidence that certain diet, is there any evidence that certain diets can prevent or delay the onset of the type 2 diabetes? Please explain, Professor Zarina.
Okay, I just need to repeat the questions. Thank you, Yusuf. I think it's one of my students actually. The question is again, is it protein diet? What was the question again? Can you repeat the question for me?
Mr. Yusuf, or I would like here, is there evidence that certain diets can prevent or delay the onset of type 2 diabetes?
Oh, I see. What kind of diet can delay?
What kind of diet?
So,
and is there any evidence?
Okay, there is evidence that dietary intake is very important, because of this behavior in certain community, the incidence of diabetes is high in certain population and certain part of the world. it goes back to the diet that is being taken by that group of people. So we noticed that the refined carbohydrate, high carbohydrate diet, high fat diet, low fiber diet can contribute to diabetes. And then secondly is the activity like low sedentary work. So previously, when our nation are mainly cultural based, taking a lot of carbohydrate is mainly for energy, to make sure that the agricultural field are being maintained. But these days, we are moving from cultural industry to industrial, cultural to industrial. So probably we don't really need too much of this carbohydrate. So cutting down carbohydrate, okay, you need to come down also on the low fiber diet also. So I must say that protein need to be maintained and fat also need to be reduced. So if you look at a lot of fast food chain, they are actually promoting a high carbohydrate, high salt diet and low protein as well as low minerals. So I think it is the imbalance in the dietary intake of the population these days have created the trends of diabetes in certain society. Not all, but in certain group of people. Okay. So I hope it answers your question.
Thank you, Professor Zarina. We would like to welcome Mr. Yusuf also in this chat. Maybe Mr. Yusuf can explore more or the explanation is enough. Mr. Yusuf? Okay. Okay, Mr. Yusuf, do you like to open the mic and maybe explore more about the answer that Professor Zarina?
Hello.
Yeah, we
Can
can
you hear
hear
me?
you, Mr. Yusuf.
Okay.
Yes.
I think so far is okay. The answer from the Prof Zarina is interesting. So yeah, I think it's enough. Thank you, Prof.
Welcome, sir.
Thank you, Mr. Yusuf. The next question is from Mr. Yanto. Ask for Mr. Ridwan and also Professor Zarina, which is the better technique to control blood glucose level on a DM patient, diet intake carbohydrate, or activity exercise?
Can you share the questions in the
Okay.
chat, because I cannot hear very well.
Okay. We will proceed, Professor. Yeah. I will add it to the PowerPoint, please. Yeah, this is the question from the chat box, Professor Zarina. So it is the better technique on controlling of the blood glucose level on the DM patient. So diet intake carbohydrates or active exercises.
Okay, thank you for the question. Actually, for diabetic patient, both are important. Actually, behavioral changes comes number one. So physical activity need to be increased. But however, diabetic is commonly seen in the elderly patient with some limited activities. So as a doctor, we have to come up with some solution on what is the right exercises for this kind of patient. Some of them may have problem with the knees, they cannot mobilize that much. So for this kind of patient, you have to go to the diet. It's easy to tell them you need to control and lose weight, but sometimes the dietitian need to look into this and to look into what are the diet that these patients are taking. You see, And some patients probably come from the lower socioeconomic groups. So you have to tailor-make the diet based on whatever is available at the place. So like in Malaysia, we have a multiracial, like the Malay, Chinese, Indians. You cannot be asking the Chinese to be eating like the Indian kind of food. So the choice or the recipe need to be tailored towards the type of ethnic group. So this is the thing that I was discussing with my colleague in biochemistry, that probably we need to come up with more books on the diet and the recipe that is tailor-made towards research, as well as supervised or recommended by the medical physicians. So we need to come up with some kind of recipe, and this need to be incorporated with dietitians and a few other groups of people. So I believe that exercise is important, but due to some restriction in elderly people, then probably diet need to come out to be taken seriously and to guide them properly. So dietary logbook must be seen also. So as new young doctors, we have to look into the history and the available resources that this patient have. Do not suggest something that is not practical, you know. And some of this good food is very expensive. So you have to tailor-make whatever they have resources. So that's my answer. Thank you.
Thank you for the explanation, Professor Zarina. Okay, one more question from our student, Gayatri, but I would like to welcome Gayatri and I'm sorry, yeah. I'm sorry. There is a question from Ratih Fitra Gayatri, Bu Ratih Fitra Gayatri, and the question is for Professor Zarina, and I'm sorry, I have to put it in a slide. Right, thank you, Brady, to share the slide. So Ibu Rati asked to Professor Zarina, I think it's important topic related to the current number of diabetes mellitus in the world. Regarding your explanation about Malaysia at the 16th of the MK in the world, I'm curious how Malaysia government to deal with this issue and what the best strategic way policy to decrease this number. Thank you very much.
Okay, thank you very much. I think it has to start from basic. So, and it has to be, it goes back to medical education, dietary education, even at school level. So the target group will be those without diabetes, especially those less than 30 years old. And then secondly, for the adults, we need to screen early. Okay, the screening should be done by all agency, whether it is private or government bodies. We need to screen. And for medical students and healthcare professionals, I think we need to have a lot of programs, outreach to the patients. Because I'm also involved with the outreach group from the private. So we do go to the outskirts of Malaysia, like in Sabah or Sarawak, and we discovered that the incidence of diabetes is also high among this group of people. So it has been associated with lower socioeconomic group of people. So I think because of the education level, as well as the availability of food that they have. So I believe that everybody should be empowered to look into these areas. For non-medical personnel, I think it should start at their office or their agency. Screen the patients, screen their staff, and then start to make diabetes as one of the important diseases that is preventable. And it's best to start early. And for medical students, I think you need to have campaigns and to go back to your respective homes and to start giving educational to your family as well as friends. I think empowerment should be at all levels, not just at the hospital level by healthcare professionals. I think that is the important message, that this should be done by all, even teachers and all staff or whatever profession.
Thank you very much.
You, Professor
Pak
Zarina.
Profesor Zarina.
Thank you.
Terima kasih, Bu Rati. And we still have one more question. This one from Mr. Wahyu. I'm sorry, Mrs. Wahyu Pujastuti for Professor Zarina also. Is there any specific efforts that we can do in presenting of diabetes mellitus in agricultural areas? Because of the pesticide exposure that causing endocrine factor, chemical, or EDC, because currently there are no different standards of care for community living in agricultural areas. Thank you. This is Professor Zarina.
I believe this question are referring to secondary cause of diabetes from chemical exposure in the agriculture. I believe in Malaysia, these are regulated, especially in those agencies that are licensed. So the exposure to the chemicals are usually under control. The only thing that we cannot control is the one that is not licensed. And pesticides also, not just to say that the local products have these problems, but sometimes the imported product. We have to see, especially the imported fruits and the one that is being sprayed with pesticide to ensure that it reaches the long area of travel to many countries. So I think education also go back to education. And one of the things that I think we need to impose on our younger generation is to start planting food source, even though it is small. So I think we have to move towards agriculture to some extent, at least for the supply of our own family. So it is important to have plots of lands, not necessarily big, because when I was studying in UK, during the fall season, sometimes we don't have much option, but to plant in pots, you know, all the simple vegetables that we can use for our domestic use. So I think all this behavior need to be calculated in among the youngsters, because youngsters are their lifestyle, if they want something that is ready-made, easily available. So I think we have to move away from that. You have to learn to be independent, get your independent food resources also, read the labels, and be very, very particular on what you take in, what you eat, because prevention is always better than cure. So if you can maintain a certain weight, you know, according to BMI, inshallah, you won't get diabetes. So at one stage, it was mentioned diabetes should be reversible. That's why we need to be aggressive on those newly diagnosed diabetes, where the HbA1c is still manageable, you know, after 3 months of treatment, and with regular exercises, especially in the young age group. Hopefully, diabetes is a curable disease and is reversible. So I hope the awareness that is created during this conference are conveyed to especially the younger generation. It can be done. Yeah. So hopefully diabetes is curable. That's my final comment.
Thank you very much, Professor Zarina. And also, I would like to Professor Aang to give insight in the biological field to answer that question also.
Could you repeat again?
Question.
Yeah, the question is it in the chat box?
Yeah, the last one.
Yeah, the last one. Yeah.
The last question.
The last question. Preventing diabetes mellitus in agriculture. Yeah. 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 I think many cause of the diabetes, I think, in our daily life, actually, based on the research even though using the rat, I think, you know, when we use the alloxan to induce the diabetes in the rats experiment, and actually alloxan also used in our daily life to make the flour for making bread become white. And otherwise it's not probably it's not good looking because it's not white. So in rat, at least in rat, I'm not really sure in human, yeah, but in rat, the data prove that using the alloxan, yeah, it can induce the apoptosis of the beta cells. Okay, so here is regarding the pesticide exposure and for the endocrine disruptor. I think in the long run, I think that will be also should take into consideration, yeah, and but I'm not sure how, yeah, to decrease the exposure, because using this disruptor or pesticide, this disruptor, the endocrine disruptor, also can cause, I think, somehow the the cell death, yeah, cell death of the beta cells. But what I know is, in terms of biology, the cells is very smart. Cells is the the smallest living organism, a living thing, yeah, in our body. So I think the cells also have the capacity to regenerate, right? Whenever there is a toxic things come to our body, they will try to regenerate. And actually, the pancreas is one of the our organs that have very high regeneration. So this is kind of very good if you have a damage, yeah. But also it can also trigger to go to the pancreatic cancer. So that's like a apa ya, knife with two two sides, yeah. So it can be good or it can be bad. So I think, yeah, factors from the environment is so many, yeah. So just be healthy, yeah, just have the healthy lifestyle. I think that's healthy lifestyle, healthy dietary, because you cannot avoid many things that endanger your health in our world. It's kind of a difficult, yeah, but have a good lifestyle, I think. Yeah. Okay. Thank you.
Yeah,
That's what I can
very important. Thank you for the explanation, Professor, Mr. Ridwan also. So that would be the last question. Thank you for the clear explanation from Professor Zarina, Professor and Mr. Ridwan. We just can give the highest appreciation with the virtual certificate that we will share in this virtual event. We would like to ask the committee to slideshow the certificate. All right. So this certificate goes to Professor Zarina. We would like to thank you, giving the highest appreciation for your willing and your explanation about the DM and a very comprehensive explanation. Thank you, Professor Zarina.
Most welcome. Assalamualaikum.
Waalaikumsalam. And also to Professor Aang, the very advanced technology that Professor Aang have shared with us. Yeah, Professor Aang, thank you very much.
My pleasure, and thank you very much for inviting me. Thank you.
You're welcome. All right. For the third speaker, we would like to give also the highest appreciation for Mr. Ridwan.
Thank you, Miss
Thank you
Anggraini.
very much. Welcome, Mr. Ridwan. All right. This is the last session, the morning session, and very insightful that we have hear from our lecturer in this session. Thank you very much. And For the next agenda, I would like to give it back to the MC, Mrs. Suti.
Thank you, Mrs. Anggraini. What an excellent presentation from our speakers. And also there's a very interesting topics. On behalf of the committee, we would like to thank to Professor Zarina Awang from Lincoln University, Malaysia, and also Mrs. Professor Anggraini Berlian from School of Life Science Institut Teknologi Bandung, Indonesia, and also last but not least, Mr. Ridwan from Poltekkes Kemenkes Bandung for the great presentation and really broader our knowledge about diabetes mellitus. Also, thank you to our magnificent moderator, Mrs. Apiti Anggraini Ayuhasuti MSc, for bringing us to a very productive session today. Once again, thank you for our awesome speakers and also moderator for this session. So ladies and gentlemen, now we will enter the break time. On behalf of the committee, we would like to thank all the participants as well as the speakers and moderators for all the enthusiasm in participating in this morning session. We would like to inform that there will be another amazing speaker after the break in the afternoon session. It is about a dietary guideline in managing diabetes mellitus, Asian herbal and traditional resources in diabetes mellitus management, and also the role of public awareness and community empowerment in preventing and managing diabetes mellitus. So please make sure that you will be rejoin us again at 1 p.m. at Jakarta time. See you in the afternoon session. Thank you very much.
Kulihat ada yang bersinar di kedua bola matamu. Oh kasihku, kau buat malam gelap ini jadi penuh cahaya, terang kilau pesona. Kasih andai anganku bersuara, dia akan bernyanyi rapsodi indah yang kan bermuara di fajar hati. Kelingking kita berjanji manis jadi saksi bahagia hingga sang bumi enggan berputar. Kau buat aku sempurna saat kau berkata iya. Kau izinkan ku berlaga mengarungi dunia di sisimu selamanya, Kasih andai anganku bersuara, dia akan bernyanyi rapsodi indah yang kan bermuara di fajar hati. Kelingking kita berjanji manis jadi saksi bahagia hingga sang bumi tak berputar lagi. Kita saling bersandar biar anganku bersuara di fajar hati. Kelingking kita berjanji jadi manis, jadi saksi bahagia untuk selamanya. Kasih andai anganku bersuara, dia akan bernyanyi rapsodi indah yang kan bermuara di
partnership network development, including research and marketing cooperation for domestic and international products. The last, dissemination of research for national, international seminar and product exhibition, and also COE special journal. Membership of Center of Excellence are Department of Medical Laboratory Technology, Department of Environmental Sanitation, Department of Nutrition, Department of Nursing, Department of Pharmacy, Department of Dental Health, Department of Midwifery, Department of Health Promotion, Bogor Nursing Study Program, Bogor Midwifery Study Program, and Karawang Midwifery Study Program. Center of Excellence is one of the organizations that focused on developing and research about science and technology and utilization the local material. Institutional characteristic, they are competitive advantage, strategic value, transfer of technology and knowledge, strong and sustainable institutions, become a national reference, world class, and being the pride of the nation. Field of development of Center of Excellence Bandung Health Polytechnic is to be the leading center for the utilization of local materials to improving health degree and community empowerment. The Center of Excellence does not only innovate the use of local products. The product will then be displayed at the exhibition to introduce the innovation product. The Center of Excellence, Bandung Health Polytechnic, actively exhibits the product in the international exhibition or symposium. The institutional synergy in higher education is to capable in the global competitiveness that involved institution, higher education and training, technology readiness, and innovation. In the future, the Center of Excellence is expected to be able to support a nation that is competitive in the world globally. Center of Excellence Bandung Health Polytechnic proudly present. Center of Excellence for Applied Science and Technology for Health Polytechnic is a research center in the Health Polytechnic independently and in collaboration with other institutions that carry out applied health research activities. These are some of our products.
Excellencies, distinguished guests, participants, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, peace be upon all of you. Welcome once again to the 6th International Conference Interprofessional Collaboration and Community Empowerment. It's very nice to see all of you once again, and we hope you have been enjoying yourself at this conference so far, as I enjoyed this conference. Excellencies, distinguished guests, participants, ladies and gentlemen, I believe that we have had productive and inspiring time together. Now we will continue of today's event. For the next session, there will be a presentation from our three delighted speakers that will be moderated by Mr. Paizar Wahyudi Askep MPH. Mr. Paizar Wahyudi Askep MPH is a lecturer from Environmental Health Department Poltekkes Kemenkes Bandung. So without further ado, please welcome our moderator for the second session, Mr. Paizar Wahyudi Askep MPH.
Thank you very much, Mrs. Switri. Ya, Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. Welcome to the second section of 6th International Conference by Interprofessional Health Collaboration and Community Empowerment Poltekkes Kemenkes Bandung. My name is Paizar Wahyudi, and I'm going to be the moderator on this section. I'm a lecturer from Environmental Health Department as part of Poltekkes Bandung, and on this section we still focus on preventing and managing diabetes mellitus through multidisciplinary approach, optimizing local materials resources, applied health science, and community empowerment. And we are super excited to have you all here as participants. And of course, diabetes has become a disease that being the government concerns, because in Indonesia, according to Institute for Health Metric and Evaluation, diabetes become top 3 disease that has caused death in Indonesia. If I'm not mistaken, International Diabetes Federation had mentioned that the number of people with diabetes in Indonesia will increase all the way up to 28.5 million people on 2045. So we gotta do something to break the chains. And to talk more about diabetes, we are pleased to have with us now 3 amazing speakers. For the first one, we have Professor Lizel M. Atinza, R&D PhD from Institute of Human Nutrition and Food, University of Philippines, Los Banos. And the second, we have Dr. Sintana Wacharasin from Faculty of Pharmacy, Burapha University, Thailand. And the third, we have Dr. Laura Raisanen from Tampere University Hospital, Finland. And for the next 45 minutes, each speaker will share their thoughts to us. And after that, we'll have kind of Q&A. So you can directly raise your hand, or you can just type your question on the chat box below. It is now my pleasure to introduce you our first speaker. Yep, she is phenomenally successful academicians, researchers, and lecturer. She got her PhD as a human nutrition minor in food science on 2016 in Institute of Human Nutrition and Food, University of the Philippines, Los Banos, and also had sandwich program for PhD dissertations from 2014 until 2016, School of Food Science and Nutrition, College of Agricultural Human and Natural Resources, Washington State University, USA. And yep, why I said she's a phenomenal, because I've read her profile and there are a bunch of achievements, awards, and publications. So maybe I can read some of them. The first one, she have Outstanding Researchers College of Human Ecology and Best E-Poster Presenter, 4th Asian Pacific Regional Conference, Best Poster Award, 48 Kapisanan Kimika, Philippines, Southern Tagalog, Best Paper Award, 2021 5th International Research Conference in Engineering and Best Paper Award PNEE International Conference and Scientific Meeting Philippines 2014 Research Paper. So would you please welcome Professor Lizel M. Atinza, RND, PhD. Hello, Prof. Have you
Hello,
joined
Sir
us?
Kaisar. Hello, good afternoon. Yeah, can you hear me clearly, sir?
Okay.
Am I
Okay.
audible?
Yeah, of
Yes,
course. Yeah,
thank you.
crystal clear. Yeah, thank you. Good afternoon.
Good afternoon, sir.
Okay. Yeah. How are you, Professor?
Yes, I'm doing good. I am now in the Philippines, where
Okay.
I'm a Filipino, of course, and thank you to the organizers who has given me this opportunity to share with you what I know about the nutritional management of diabetes. Me as a nutritionist dietitian and as a professor in nutrition.
Okay. Yeah, thank you so much for joining us. How to say good afternoon in Philippines? Is it magandang hapon? Is it correct?
Yes, sir. Correct.
Okay. Okay, thank you.
Magandang hapon.
Without further ado, let's just take your time whenever you're ready. Professor
Okay.
Lizel M. Atinza, please.
Yes, thank you so much. So let me just share my screen. I'll just fix my screen a bit. All right. Can you see my screen now?
Yep, it's already shown.
Okay, thank you so much, sir. So again, good afternoon, everyone. Good afternoon there in Indonesia. I hope you're all doing well. And again, thank you so much to the organizers of this international conference. So for the outline of my presentation, I am going to discuss with you some information about the background of this disease condition, which is the heart of the matter or the topic of the conference, including the prevalence and definition of diabetes mellitus, the classification, signs and symptoms, and pathophysiology of this disease condition. Of course, the heart of my talk, which is about the nutritional management and the practical tools in meal planning for people with diabetes mellitus. So just a background for this disease condition. So diabetes is really a serious public health concern worldwide, in the Philippines, in Indonesia, and in the whole world. And it is one of the prevailing non-communicable diseases globally, mostly affecting the adult population in disadvantaged nations, including Philippines as a developing country. And sadly, at the global level, a lot or millions of people remain undiagnosed with this condition, meaning they have the disease, but they are not aware of it. And currently, there are around 537 million adults with ages 20 to 79 years old living with diabetes, and it is projected to increase to 643 million by 2030. So the rise in this disease condition is fueled by the global rise in the prevalence of obesity and unhealthy lifestyle, according to studies. So to simply describe this condition, the diabetes or diabetes mellitus, it is actually not a single disease, but a disorder or a combination of symptoms, okay, that is influenced by many factors. This disease condition is actually called as a multifactorial disease because it is influenced by many factors. And the feature of this disease condition or the characteristic is hyperglycemia. I know that you're all aware already given your medical or their health background. And according to the World Health Organization, for a person to be diagnosed with diabetes, the cutoff should be, the cutoff for the blood sugar level should be greater than or equal to 100 milligram per deciliter. So diabetes happens due to lack of insulin. Insulin is a hormone that controls the amount of glucose in the blood. So if there is not enough insulin, blood glucose levels can become too high, which causes a range of problems over time. And several pathogenic processes are involved in the development of diabetes. They range from the autoimmune destruction of the beta cells of the pancreas, or it happens when, for example, a person or at a young age was exposed to infection, causing a destruction of the cell in the pancreas or the beta cell that is responsible for the release or production of insulin, causing deficiency in insulin production. And it can also be due to the insensitivity of insulin or of the cell because of insulin resistance or insensitivity of the cell to the action of the insulin because of insulin resistance. So later on, we'll discuss a little bit about this terminology. So regulation of glucose in the body is done automatically and constantly throughout each minute of the day to adequately meet the energy needs of the body, especially the brain. So it is largely done by the endocrine hormones of the pancreas, the balance of hormones achieved through a negative feedback loop. The primary hormones that are responsible for blood glucose regulation are the glucagon and the insulin. Okay, so what happens is that when the blood glucose level is high, the insulin, the pancreas, the beta cell of pancreas will secrete insulin that will prompt the blood glucose to enter the cell so that they can be metabolized into important compounds like glycogen or the stored form of glucose. When the blood glucose gets low, on the other hand, the alpha cell of the pancreas will secrete glucagon, and its action is to increase the glucose level in the blood or to mobilize the stored glucose. So in normal individual, glucose regulation is never a problem. The glucose level is maintained at normal level, and that is around 60 to 140 milligram per deciliter at non-fasting state. So, interestingly, the pathophysiology of diabetes mellitus has evolved over time. From the simple insulin defect involving the pancreas to a pathophysiology involving various organs in the body, including the brain. As we all know, the brain is the organ in the body that regulates satiety. It prompts us, or it gives us the sense of, or the feeling of fullness, no? Right after eating. So when there is a defect in this, the brain chemicals that is responsible for the regulation of appetite, for example, then it can contribute to hyperglycemia. Another is a problem in the liver. The liver can be the problem when it comes to hyperglycemia. There can be an increase in metabolic activity like gluconeogenesis or the utilization of glucose or production of glucose from non-carbohydrate sources, and so leading to increase in blood glucose contributing to hyperglycemia. Another organ that can be a problem is the pancreas. So there can be problem in the secretion of insulin and glucagon, which I've already discussed earlier. Another is the intestine. There can be a problem with intestine. The intestine might not be producing the necessary compound that will help regulate the appetite and food intake, as well as insulin secretion. So that can also contribute to hyperglycemia or abnormal glucose level. Another organ that is involved in hyperglycemia or diabetes is the kidney. In the kidney, some glucose are synthesized via this pathway, the gluconeogenesis. And if there is also a problem in the kidney, like if there is a lot of sugar already going to the kidney through the blood, then it can increase the glucose reabsorption. And so more glucose will be retained in the blood, okay, contributing to hyperglycemia. Another organ is the adipose tissue. So the adipose tissues house these chemicals that are involved in the regulation of inflammation. So when there are a lot of adipose tissues, then there can be a lot of inflammatory cytokines that can promote insulin resistance. And insulin resistance is a problem on adiposity that can contribute to the development of diabetes. Okay, and lastly, the muscle, which is responsible for the absorption, or the one that is housing or houses the glycogen that is or the overload of exogenous glucose, the ones that can no longer be kept by the liver are transported to the muscle for storage in the form of glycogen. So if the muscle is not resistant or is not sensitive or is resistant to the action of insulin, then there can be or the glucose in the blood won't be that taken up adequately, and they can contribute to hyperglycemia. So just that is now the considered pathophysiology of diabetes. And it's no longer just the traditional or the old idea that we have, or old concept that we have, that it's just because of the problem in the pancreas. So diabetes has many classifications. We're in type 2 diabetes as the prevailing form or type of diabetes in the whole world. According to the statistics in 2021, 90% of the diabetes is type 2 or are type 2 diabetes or is type 2 diabetes. Other classifications of diabetes include type 1 diabetes, that is immune-mediated, okay, that cause the destruction of the beta cell responsible for the secretion of insulin. So when the beta cell is destroyed, then insulin deficiency can result. Another is gestational diabetes. This is the form of diabetes among pregnant women. They experience glucose intolerance, not because they lack insulin, but because of the hormones, the placental hormones and other pregnancy hormones that counteract the activity of insulin. This condition manifests during the second and third trimester of pregnancy. And the last one are the specific forms of diabetes contributed by other factors like genes. So genetic defect, chemical or drug-induced infections, genetic syndromes, or diseases of the pancreas, or other causes of diabetes. And they have a different set, or they are classified under a different classification, not under type 1, type 2, or gestational diabetes. So I'd like to simply present. I know that most of us are already familiar with the classical symptoms of diabetes, and these are the 3 Ps. Sometimes they call it 4 Ps. So 3 Ps, because there is P1 for polyuria or increased urination among people with diabetes. or experiencing high level of glucose in the blood or hyperglycemia. Okay, another P for polyphagia means increased appetite. A diabetic person don't always feel hungry. Okay, they have the reduced satiety or feeling of fullness. Okay, and then the third P is polydipsia or increased thirst because of the high level of sugar in the blood that exert osmotic effect, no? So causing dehydration because of the osmosis, more water is excreted, no? Together with the urine, and so the person feels thirsty and is always looking for a drink to satisfy the thirst. So these are just some of the classical symptoms. Sometimes there's another P for pruritus or itching, and some people have other symptoms, signs and symptoms such as rashes, nausea and vomiting, blurry vision, and tingling in hands and feet. So now, what I'm showing with you is the a simple visual on the complication of diabetes mellitus. The blue ones are called the traditional complications because, as we all know, uncontrolled diabetes can lead to destruction of the small blood vessels in the kidney. It can lead to a condition nephropathy, and it can result in kidney disease. Another is it can affect the nerves, okay, in the eyes, and so vision is affected. The condition is called retinopathy, and it can also cause damage to the nerves in the hands and feet in the peripheral areas, and the condition is called neuropathy. And then we have another set of complications, okay, because of the damage that diabetes has caused to the large blood vessels. So one of which is the blood vessel that supply the heart with oxygen and nutrient. And so it can lead to coronary heart disease. Another is stroke and the peripheral vascular disease. The one is the artery affecting the artery located in the peripheral areas like the feet. And then for the emerging complication, interestingly, there are no reports that diabetes can increase the chance of developing cancer, infections, and liver disease. And it can also affect other domains such as functional, it can lead to functional disability, can also lead to cognitive disability and affective disorders. So these are based on recent studies. So now what to do? So diabetes, just like other chronic conditions, require long-term management. So management include a combination of diet, exercise, medicine, and self-monitoring of blood glucose level. So all of them are equally important when it comes to the management of diabetes. And so a person with diabetes has to make lifestyle adjustment. He or she needs to follow a certain diet, increase her or his physical activity, okay, be mindful of on how he or she copes with stress, and do a regular glucose monitoring. So the aim of all of this is to return blood glucose or the blood sugar to a safe threshold and reduce the risk of complications. So as a nutritionist dietitian and as a professor handling nutrition courses, so I'll be focusing on the nutrition therapy for diabetes. So these goals are indicated or are mentioned in the consensus report by the American Diabetes Association published in 2019. So the goals of the nutrition therapy for diabetes are the following. One is to promote and support healthful eating patterns, emphasizing a variety of nutrient-dense food. So the goal is to achieve and maintain body weight goals. So a diabetic person must maintain a body weight that would yield in a that will provide level of glucose, blood pressure, and lipids that are normal or near normal if attaining the normal level is not possible. And then attain individualized level of glucose or glycemia, blood pressure, the lipid goals, including the level of total cholesterol, low density, high density, lipoprotein, and triglycerides, and to delay or prevent the complications of diabetes. And then the second is to address individual nutrition needs. So, interestingly, the second goal is focused on individualized or personalized nutrition care for a person with diabetes, because the person in charge or the nutritionist, together with the client who is diabetic, must consider a lot of factors that would make the nutritional care plan more individualized and personalized, such as the client's personal and cultural preferences, the level of understanding when it comes to health, and the person's access to healthful food choices, the person's willingness to and ability to make behavioral changes, as well as barriers to change. And then the third goal is to maintain the pleasure of eating. So there is this focus on pleasure of eating. So diabetic people should not feel deprived, that they will feel that they are no longer they no longer enjoy eating, because that as reminded by the American Diabetes Association, there should be this pleasure of eating by providing non-judgmental messages about food choices, because most of the time diabetic people or people with diabetes are left with limited food choices. They feel that they don't have so much choices anymore when it comes to healthy eating. And the number 4 is to provide an individual with diabetes the practical tools for day-to-day meal planning. So they must be empowered on how to make healthy food choices using practical tools in meal planning, rather than just focusing on individual macronutrients, micronutrients, or single foods. So now let me go over the nutritional management according to energy and nutrient provision or recommendation to people with diabetes. In terms of energy, how much energy do you think a diabetic person must be provided, or a diabetic person needs? Okay. The computation for the total energy provision or recommendation is dependent on many factors, including age, height, weight, health condition, and a lot more. So it would also depend on the person's food tolerance, or how much a person can tolerate. So the energy provision or recommendation must be individualized, or in other words, personalized. It should be sufficient to help the client attain and maintain ideal body weight. But for clients who are overweight and obese already, they must be provided with a calorie-restricted diet to promote weight loss. A target is a moderate weight loss of at least 5% of body weight in 3 to 6 months, okay, for overweight and obese client. So how important is weight loss? Diabetic person, especially the type 2, can have a lot of adipose tissues. And these adipose tissues is causing inflammation and insulin resistance, and they have to be reduced, or this excess adipose tissues must be get rid. No, there must be a weight loss in order to get rid of this excess adipose tissues. Okay, so studies have shown, or it is now well recognized, the role of inflammation as a link between adiposity and diabetes. So there are a lot of studies on specific foods or functional foods, checking for their ability to promote anti-inflammation and their effects on metabolic disorders like diabetes. So going back, what we're pointing out here is that there is a need to lose weight for a person who is or diabetes and is overweight or obese, in order to lessen the inflammation, lessen the insulin resistance, and help achieve the normal level of blood glucose. So recent studies have shown that there is really good news when a diabetes person lose weight. A weight loss of 7 to 10% among pre-diabetics or individuals who do not have diabetes yet, but they fall under the impaired fasting blood glucose category, wherein their blood glucose fall below greater than 100 but less than 126 milligram per deciliter, then they can prevent or delay getting type 2 diabetes, no, by losing weight. And the goal is to lose weight up to 7 to 10% of their current weight. For people who are already diabetic or they already have type 2 diabetes, they are recommended to have a more intensive weight loss, 15%, to help maintain normal blood sugar level. And have you heard of this, that diabetes can be reversed already? Before, we thought that diabetes is a lifelong disease. Yes, it's still a lifelong disease, but remission is possible. Okay, remission means that a person with diabetes can maintain a normal level of blood sugar without the use of drugs. Okay, so according to American Diabetes Association in 2021, diet remission indicators, or how can we say that the diabetic person has or was able to achieve remission? When the hyperglycemia, or the level of blood glucose, is below the diagnostic threshold for diabetes, at least 3 months after cessation of pharmacotherapy or surgery, and an HbA1c of less than 6.5%. As we all know, HbA1c is another indicator of blood glucose level. But the one that it is checking is the long-term glucose control, because what it measures is the glucose level for 3 months, the average of the glucose level over the period of 3 months. Okay, and now let's move on to protein. Protein is equally important as energy. Protein is a macronutrient. We don't normally use protein as a source of energy, but for diabetes, sometimes protein is used up when there is not sufficient carbohydrate or glucose in the blood. So proteins has a lot of functions in the body, in addition to providing compounds that is important for the immune system. The recommendation for protein is 15 to 20% of the total energy requirement. So if the total energy requirement of a person is 2,000, then simply multiply 0.15 or 0.20 and then divide it by the calorie per gram of protein, which is 4, then you'll get the actual amount in grams of protein. But for people with kidney disease, or there is a sign already that the person is developing a kidney problem related to diabetes, then he or she is given a lower amount of protein, or recommended with a lower amount of protein, and that is 0.8 gram per kilogram desirable body weight. So, are proteins equally, are treated equally or created equally? Okay. So before we answer that, let's have a little run through of the functions of protein in the body. As I've mentioned, biochemistry shows that some amino acids, especially the glucogenic amino acids, if you are familiar with it, are converted to pyruvate. So if you have a background on biochemistry, I'm pretty sure that you can still remember this pathway. When converted to pyruvate, they can be converted back to glucose. So this is just telling us that some amino acids from proteins can be a source of glucose whenever needed. But this is not the major function of protein, because the major function of protein is to provide compounds, or to provide to help in the synthesis of compounds that are important for the immune system, like the synthesis of antibodies, synthesis of hormones, synthesis of enzymes, and a lot more, as well as in muscle building. But there are times, for example, when the diabetic person is not consuming enough of the energy nutrients like carbohydrates and fats, then the stored muscles will be used up as source of energy, and that is not good, because the person can develop muscle wasting. Okay. So other functions of proteins in diabetes management is that proteins enhance satiety and thus promotes weight loss. So with protein in the diet, the person will feel full. And so the person may not be eating so much. And that can help in weight management. And how? It is through the stimulation of the appetite-regulating gut hormones such as cholecystokinin, peptide Y, and incretin, the glucagon-like peptide 1, which promotes satiety or feeling of fullness. And the most recent studies are focused on peptides. Peptides are bioactive compounds from protein foods. And they have found out that they can contribute in decreasing the glucose uptake, and so helping in the regulation of blood glucose, especially among people with diabetes. Specifically, the study presented here worked on, or they use casein and fish gelatin as the raw material for their experiment. So are proteins created equal when it comes to nutrition for the general healthy population and for for people with diabetes? They are not treated equal. Based on the consensus report of the American Diabetes Association, good sources of protein are the lean animal proteins, such as the skinless poultry and lower fat cuts of beef or pork and fish. It was also mentioned there egg, the reduced fat dairy products, such as low fat and skim milk and yogurt, and cheese. And of course, the plant proteins, such as tofu, tempeh, legumes, and others. There are also meat alternatives, but when processed, they are not as healthy as the natural forms because of the added preservatives. So be aware of the possible higher sodium content. And the proteins in nuts and seeds, okay, and in nut butters. So these are the set of protein sources that are mentioned in the consensus report, the most recent set of recommendations by the American Diabetes Association, where most of our guidelines are tailored. Okay. Next is fats. So fat is part of a healthy diet, healthy balanced diet for people with diabetes. However, some fats are not good, especially the saturated fats from the animal sources, because it
belum
can
diajukan kemarin.
increase the risk of heart disease or stroke.
Bu Ari belum kasih info lagi.
So, the recommendation is to keep the saturated fat to fewer
Iya,
than
yang saya bilang
7%
udah data-data katanya hilang kamu
of the
mana
total
tuh? Dia juga bilang kok begitu.
Sorry.
energy intake, and to avoid the intake of trans fats or industrially produced fats. So again, the saturated fat should be less than 7% of the total energy requirement. So if you know your energy requirement, for example, your energy requirement is 2,000, then simply multiply it by 0.07, divide it by 9, which is the calorie yield from a gram of fat, then you'll get the gram of fat, the equivalent grams of fat allotted per day. So there is also the reminder to minimize or avoid or eliminate trans fat. So in the Philippines, we have this bill, which is now being worked out to be a law. That is the trans fat-free Philippines, wherein we are trying to eliminate, if possible, the trans fats in the food chains, because trans fats are really bad fats. They double the trouble. So we'll see later what are their effects to the body, especially for diabetic people. So let me just share with you some findings of the recent study on the health benefits of substituting saturated fat. So what happened when we substitute or replace saturated fat with unsaturated fat? So by the way, if all of us are not yet familiar with the fat classification, as you can see in the figure, fats are classified into saturated, which are mostly from animal sources, but it also include the palm oil and coconut oil. There is this unsaturated fat, which is divided into two classifications, the polyunsaturated and monounsaturated, based on their chemical structure, which influence their feature and actions in the body. So unsaturated fats, which are mostly from plant oils, and the ones from marine products, are considered healthier fat options than the saturated fats. Okay, so this study attempted to replace saturated fat with unsaturated fats. And they have found out that doing it can reduce both total cholesterol and low-density cholesterol, or the bad cholesterol. And replacing saturated fat with monounsaturated fat from plant sources such as olive oil and nuts reduces the risk to cardiovascular disease. So there is a health benefit of doing this substitution, replacing the form of fat in our diet from the saturated with unsaturated fat. And what about replacing saturated fat with carbohydrate? Because there are people who are fond of eating fatty foods, and they do it because they think that it can help them control their blood sugar level. But substituting saturated fat with carbohydrate yield good results because it was able to reduce the total cholesterol and the low density lipoprotein cholesterol or bad cholesterol, but it was seen or reported that there was a significant increase in triglycerides and a reduction on the good cholesterol or high density lipoprotein cholesterol. So in nutrition, we are always reminded to consume in moderation. The same message that we need to share with people who have diabetes, that they do not overemphasize the use of a specific or the consumption of a specific food item, but consider their overall intake, balanced eating, wherein there is a principle of moderation and variety. Another study which answered the question, what about the extra virgin coconut oil or the nuts, which is also rich in polyunsaturated fats? So according to this study, when a Mediterranean style eating pattern, wherein a Mediterranean diet is described to have plenty of plant foods. There are also legumes, low in meat and meat products, and with red wine. And when that kind of diet is added or supplemented with extra virgin olive oil and with nuts, then it was reported to reduce the incidence of type 2 diabetes. Another study is the intake of saturated fat from dairy products, coconut oil, and palm kernel oil were associated with lower diabetes risk. This is a very interesting findings because we normally think of saturated fats as bad fat or not as good as the polyunsaturated and the monounsaturated fat. But the message here is that they differ. Not all saturated fats have the same actions and characteristics that influence the activity in the body because, as seen here, saturated fats from specific sources such as dairy products, coconut oil, and palm kernel oil were actually associated with lower diabetes risk. And what about omega-3 supplementation? There are reports on the beneficial effects of fish oil on insulin resistance. As we all know, fish oil is a rich source of omega-3 fatty acids such as eicosapentaenoic acid or EPA and the docosahexaenoic acid or DHA, which are good for the brain and the vision, especially among young children. So there is evidence for the role of the omega-3 fatty acids on insulin resistance and diabetes. However, in this study, the most recent ASCEND study of cardiovascular events in diabetes trial, when compared with placebo, supplementation of omega-3 fatty acids at the dose of 1 gram per day did not lead to cardiovascular benefit in people with diabetes without evidence of CVD. And omega-3 fatty acid supplements have not reduced CVD events or mortality in randomized trials, but may have utility in people who require triglyceride reduction. So given all this, the stand of the American Diabetes Association is that evidence does not conclusively support recommending omega-3 supplements for all people with diabetes for the prevention or treatment of cardiovascular disease. What about trans fat? As mentioned, trans fat is a very bad fat that doubles the trouble. It means it reduces the good cholesterol and it increase the level of bad cholesterol and total cholesterol in the body. So numerous studies have concluded that trans fatty acids significantly increase the risk of metabolic diseases such as type 2 diabetes and fatty liver. Trans fats may drive insulin resistance and type 2 diabetes. In a meta-analysis of 7 randomized controlled trials, it was shown that increased trans fat intake did not result in changes or improvement in glucose, insulin, or triglyceride concentration, but led to an increase in total and low-density lipoprotein cholesterol or bad cholesterol, and a decrease in high-density lipoprotein cholesterol or good cholesterol concentrations. And trans fats also have been associated with all-cause mortality, total CHD, and CHD, coronary heart disease mortality. So as you can see in the picture, trans fats are fats that are produced from, that can be found in processed foods. There are also trans fats in natural foods like the dairies from the ruminants. But according to studies, the health effects from the trans fats from the ruminants or natural sources are not bad. The ones that are bad are the trans fats in processed foods or the industrially produced trans fats, or other name for it is partially hydrogenated oils. So they can be found in many of our favorite foods like cookies, microwavable popcorns, French fries, donuts, and a lot more. Okay, so these are some of the practical tips on fat intake, especially for
Sorry,
people
Professor.
with DM. Yes?
Sorry. We ran out of the time. Maybe you still have like two minutes more.
Okay.
Yeah.
Okay, so limit this. Thank you so much. Limit the saturated fat intake by replacing animal meats with plant proteins. So now, the carbohydrates. So this is the most important food component, energy yielding nutrient in a person with diabetes. The recommendation is quite low, lower than the recommendation for the general population. That is around 45 to 60% of the total energy requirement. And the focus is consistent or controlled carbohydrate. That means similar amount of carbohydrate for every meal as much as possible at regular times. And complex carbohydrates, the use of the tool glycemic index and glycemic load, and to avoid sugar and sweetened beverages and fruit juices. So we focus on complex carbohydrate, that is from plant sources that are rich in fiber and some essential nutrients such as vitamins and minerals. For the simple carbohydrates, such as sugars and sugar-sweetened beverages, the recommendation is not to exceed 10% of the total calorie requirement. So one interesting topic is the resistant starch. This is the form of starch that is not digested in the intestine, and they are fermented by the gut microflora in the large intestine. The resistant starch has 5 types. But interestingly, let us focus on this one. There is a publication from Indonesia which reported that resistant starch found in cooled rice, that is cooked rice cooked for 24 hours at 4 degrees centigrade, have lowered glycemic response, or promote a lower glycemic response, making it a good food for everyone, including diabetes. And that is because of the resistant starch that is present in the cooked rice. So resistant starch yields short-chain fatty acids, and it leads to many metabolic processes that help control the insulin response to food and blood sugar level. So this is glycemic index. This is the scoring of food based on their ability to increase the blood sugar level after a meal. The lower the glycemic index, the better, especially for people with diabetes. Because the lower the glycemic index, the slower blood sugar rises after eating a meal. And foods that are rich in dietary fiber are generally low in glycemic index. And then another one is the glycemic load. It's another tool that can help a person make healthy food choices, especially for diabetic people. So this is may not be that familiar with everyone. This is actually can be computed by using the glycemic index of food multiplied by the amount of available carbohydrate in food. The table shows you the listings of the GI of some foods as well as the the glycemic load. And I've highlighted two just to show you that the food may be high in GI but low in glycemic load. And that makes it still a good food for diabetes or diabetic people, okay? And then cholesterol should be less than 200 milligrams per day. Fiber should be 25 to 35 grams per day, which can be consumed from having at least 5 servings of fruits and vegetables. Okay, so there are a lot of activities or benefits that fiber can give to the body, especially when it comes to body weight management and blood glucose control. And then sodium should be less than 2,300 milligrams per day, proven to be effective in reducing blood pressure. So just 4 remaining slides. So we have different eating patterns. Some of you may have encountered this or have tried this already, the Mediterranean style, vegetarian or vegan diet, low-fat diet, very low-fat, low-carbohydrate diet, very low carbohydrate, dietary approaches to stop hypertension. So which one is the best for DM? The stand or the consensus is a variety of eating pattern is acceptable as long as they incorporate different food items, especially the non-starchy vegetables. So a diet that is rich in plant foods and dietary fiber with low sugars and refined grains are acceptable. Okay, whole processed foods over whole unprocessed foods, fresh foods over processed foods are better. And a reduced overall intake of carbohydrate, especially for people who have poor glucose control. And then last 2 slides, these are two tools on how to help or to empower a person with diabetes in making healthy food choices. So this is just a simple tool, a visual tool, wherein a plate, okay, is divided into portions. Half portion is for non-starchy vegetable, mostly green leafy vegetables. And then 1/4 for carbohydrates that should be complex carbohydrates and lean proteins. And water, plain water or 0-calorie drink like unsweetened tea or coffee is better than the sweetened ones. And then the last one is the portion control. Okay, the portion control will help the diabetic person to make healthy food choices by being familiar with the different food portions using hand. So keeping the portion sizes in check is important for managing type 2 diabetes. And so getting familiar with portion control will help people with diabetes to not consume calories and carbohydrates more than what are recommended for them. So thank you for extending my time allowance. Okay, thank you so much, everyone, and thank you so much, sir.
All right. Thank you so much, Professor Liesel, for sharing. That was an amazing explanation about dietary for diabetes. Unfortunately, we have limited times. Actually, I want to hear more about dietary. It's quite interesting because uh, I'm the one of focusing on building muscles. It have correlation on that. And we hope you keep staying with us, by the way, because for the next two speaker, if you don't mind, Professor, because we still have Q&A sections after the third speaker. Okay, moving along, that was only the beginning. Now we move to the second speaker, and she also an amazing person. Yeah, I have read her profile and I found that there are so many achievements, research articles, and even she wrote a book. Okay, she got her bachelor in at Konkan University, Thailand, as nursing midwifery, and then he got she got her Master of Science Public Health at Mahidol University. I got a friend from there, Thailand, and then he got Master Science of Nursing, University of Washington, just like Professor Liza Latinza, USA, with major pediatric nursing. And then she also got her PhD as a nursing science, also at University of Washington, USA, in 2001. And right now, she is associate professor at Burapa University, Thailand. She also served as a director of a research division, Faculty of Nursing at Burapa University, Thailand. Please welcome Dr. Chintana Wacharasin from Faculty of Pharmacy, Burapa University, Thailand. Good afternoon,
Good
Dr.
afternoon.
Chintana.
Good
Hello,
afternoon,
doctor.
everyone. Okay,
Yeah,
see
good.
you
Yeah,
again.
good to see you. Okay.
Okay.
How are you, doctor?
Yes, I'm fine. Try to listen to the speaker. It's very
Okay.
interesting webinar today, huh?
Yeah, I'm glad to see
Okay.
you too.
So can you see my PowerPoint?
Yeah, I can see it clearly. We know you are a busy person, so thank you for taking time to join us. And without any further ado, the screen is yours whenever you're ready.
Okay. So you see the full screen, right?
Yep.
Okay, so the very interesting topic for today, Asian herbal and traditional resources for NDM management. Actually, I believe that almost every family use some herb, right? For that treatment for some kind of disease. Okay, NDM is one of disease that people already use herbal, or we call medicinal plants. Okay, this is overview. And we know that like 1 of 10 adults, or 10%, 10.5% of population is 20 to 79 have DM type 2. And we know that DM type 2 is metabolic disease. This persistence of hyperglycemia primarily caused by insulin resistance and oxidative stress, glucose, lipids, metabolism, inflammation, and immunity. Okay, so the goal or the objective of for the management, we try to reduce insulin resistance, to reduce oxidative stress, or to normal glucose and lipid metabolism, or reduce inflammation and immunity or immunization. Okay, so as we know that there are many series of complications of the people with DM, especially type 2 DM. Okay, since the type 2 DM decrease insulin resistance, increase insulin resistance, and increase insulin level, and cause variety of symptoms like hyperglycemia that sometimes have crisis, hyperlipidemia and hypertension. Okay, and they have from this pathology they have series of complications like stroke, DM, retinopathy, DM, diabetes, neuropathy, coronary heart disease, nephropathy, diabetic, angiopathy, or Alzheimer, and also hearing impairments, and also depression. These are the complications for DM. So, as we know that there are many synthetic drugs had been developed to treat the DM, but on of those is the patient of DM or people with DM who still have suffering from controlling blood sugar and also the quality of life. Okay, so even there are many medication use it. Okay, but it's just like a three kind of modern medicine that they use. For example, they use insulin injection, use oral hypoglycemic drug, and also some use bariatric surgery in order to reduce of absorption of glucose. Okay, these three methods that can reduce blood glucose to improving the body glucose metabolism. But long-term insulin injection that might produce insulin resistance and decrease body endurance insulin protection, enhancing patient to have insulin dependence. Okay, so as you can see, this is the medication, modern medicine that they use to get the outcome to reduce outcome for DM management, to reduce blood glucose in order to prevent hyperglycemia. For example, carbostatin, this medication that affect intestines to inhibit the absorption of starch or carbohydrate. And this one, savonylurate, this one, the effect at pancreas to improve to stimulate the pancreas secrete more insulin. Okay, and then also this metformin or TZD, this is effect to liver and also effect to the adipose tissue. Okay, in order to reduce the oxidative stress, and also some medication, metformin, that is a very like a famous medication that they use for DM. It's an effect to muscle. Okay, also to reduce oxidative stress. And okay, so these are the modern medicine. But today I would like to focus on the traditional medicine for DM. In Asian country, every country we believe that they have traditional medicine, like Chinese, as we know that very famous for Chinese traditional medicine. Okay, and Thailand also have Thai traditional Thai medicine. Also in Indonesia, they also have traditional Indonesian medicine for DM. Okay, so as we know that DM is chronic disease that cannot be cured, but we can use traditional medicine or some we call herb or medicinal plant that can use to prevent either to prevent DM or to treat DM. That the main fact, as we know, the main factor for DM type 2 is inappropriate eating behavior and also inappropriate self-care. Okay, so it's like a behavior have caused DM, not only eating behavior, but including exercise or rest or stress reduction. Okay, so if we can do those, improve the eating behavior and like a less stress and have exercise, maybe DM type 2 can be controlled. Okay, so although treating DM had been significant progress, existing clinical drug for diabetes, but can no longer fully meet patient needs. Okay, that's why medicinal plants are this resort of anti-diabetic compounds such as flavonoid, alkaloid, phenolic, and tannin that improve efficiency of pancreatic tissue by increasing insulin secretion or decreasing intestinal absorption of glucose. Okay, these are the purpose of using traditional medicine to prevent or to treat the DM. Okay, medicinal plants have a phenolic compound, flavonoid, terpenoids, and curamine, which is responsible for the anti-diabetic nature and reduction of the blood glucose level. The active principle derived from plants work through many anti-diabetic mechanisms that include inhibits alpha glucosidase, alpha amylase, and protein tyrosine phosphate. Okay, and several medical plants extract had been shown to modulate metabolic pathway such as glycolysis, gluconeogenesis, Krebs cycle, glucogen synthesis and release of insulin, cholesterol synthesis, carbohydrate metabolism and absorption. Traditional medicine had unique understanding of diabetic treatments and had developed many classic and practical prescription targeting DM. Some medicines, when we call medicine, like they use many kind of herb or medicinal plants combined together. And for example, this is a traditional Chinese medicine. There are many kind of medicine plants that can use as a medicine to prevent DM and also treat DM. Okay. Management of DM often involve the combination of lifestyle modification and medication, and also some complement therapy. Okay, not just only for the medication. In some Asian countries, herb and traditional resource had been used for many centuries. I think any country have those traditional medicine. There are some Asian herb and traditional resource that had been studied for benefit and in diabetic management. And some of these treatments can control blood sugar, but also scientific evidence support the efficacy and safety is not always robust. It means we still have to study to see the side effects of those medicinal plants, like a traditional medicine that we use. The health risk of medicinal plant should be concerned, and it's also important to consult healthcare provider, healthcare personnel before using new treatment for DM management, because when they combine the medicinal plant together, and they might have some interaction effects, okay, and then might have side effect for the people, and also individuals are different. Okay, this is example of traditional Chinese medicine that used for DM, and this is proved by the research evidence that can use for DM prevention and also treat medicine. For example, I think everyone know this one, bitter melon. Okay, so bitter melon is commonly used as a vegetable. Okay, I see from the study also in Indonesia, Thailand, China, they use bitter melon. Okay, that is it good that good for anti-diabetics? Some studies suggest that bitter melon may help low blood glucose level, and also compounds may have insulin-like effect, stimulate the uptake of glucose into muscle cell, and respond similar insulin. And the second one, this one, I don't know how to say it. Fenugreek, that is they use seed at risk of soluble fiber that used for potential to lower blood sugar and improve insulin sensitivity. Okay. And cinnamon, I think everyone knows cinnamon. Cinnamon also used at the Asian cuisine that is potential for anti-diabetic effect. It can improve insulin sensitivity and lower blood glucose. Okay, and also it has been reported that the exhibit of anti-diabetic activity by regulation of glucose level, lipid metabolism, repair of pancreatic beta cell. Okay, and then the third one, ginseng. I think everyone knows ginseng, right? Ginseng also used as a traditional medicine. Okay, and this have potential for benefit for diabetes. Okay, because they have improved insulin sensitivity and lower blood sugar. Okay, and turmeric. This is a very common. Turmeric is contained with curcumin, which had anti-inflammatory and oxidation property. Remember because the cause of diabetes, including the insulin resistance, oxidative stress, right? Inflammation, immunity, and also metabolism of the glucose and lipids. So any medicinal plant that have that property, so they can use for anti-diabetics. Turmeric also as well, used for anti-inflammatory. Aloe vera, this one is also the potential to use for diabetes. And studies suggest that aloe vera also may have glucose hypoglycemic effects. Okay, and neem, this is the many countries use this one. Neem has been used for traditional medicine in Asia and have variant effect of the health. Okay, and this one is have anti-hyperglycemic effect. Okay, and also effectively reduce level of hemoglobin A1C and inhibit occurrence of inflammation, oxidative stress, hypertriglyceridemia in the patient who treat with metformin. Okay, many countries use this one. And then this one, cordyceps militaris, that is actually this one is it's like a mushroom but it's can found in the cold zone of high altitude, like a highland, high mountain, like somewhere in Tibet or in China. Okay, this one approved renal fibrosis in rats and with diabetic nephropathy by inhibiting inflammation and regulating intestinal flora imbalance. Cordyceps has a protective effect on diabetes nephropathy through autophagy activation and also protect against chronic hypoxia injury in diabetes nephropathy and by lowering expression of HIF-1 alpha and VEGF and protect renal function of diabetes nephropathy. And then number 9, ginkgo biloba. This one also have in many countries. In Thailand also we use this ginkgo biloba. Okay, but this is kind of good because it's negative effect on liver, kidney, or hematopoietic function. This finding indicate that ginkgo biloba is safe and effective treatment for diabetes. Okay, promotes blood circulation, remove blood stasis. Okay, and tea. Everyone know that tea is also good for anti-diabetics. Okay, they have green tea, white tea or oolong tea. There are many kinds of tea that can effectively increase glucose tolerance. And also green tea can treat diabetic nephropathy by inhibiting hyperglycemia, prevent glucagon accumulation that in proximal tubule and improve serum and urine parameter. And also white tea can reduce blood glucose level by increasing insulin sensitivity and the liver glucagon synthesis. And oolong tea also regulate postprandial blood glucose by inhibiting alpha glucosidase. And then another one, grape, proanthocyanidin from grape. You know, everyone know grape, right? So this is the anti-diabetic effect of proanthocyanidase. It's not limited to regulation of blood glucose, but also have significant therapeutic of kidney disease, liver disease, cardiovascular disease, pancreatic inflammation. So that's why this can help to increase the insulin secretion. Okay, and also the grape had a therapeutic effect, also relate to antioxidant activity, and also have a effect on diabetic nephropathy. And also procyanidins can increase mRNA express of NRF1 or TFAM and mtDNA that can help for anti-diabetes. Since diabetes caused by the inflammation, so this one grape, it can reduce the inflammatories. And then mulberry leaf, you know mulberry, right? So mulberry also significantly inhibit glucose transport and inhibits rate increase with time of concentration. And also mulberry comprise chlorogenic acid, rutin, benzoic acid, and hyperoside. So blood glucose lowering effect of mulberry leaf with no toxicity in liver and kidney. This is good for diabetes. Okay, and also ginger. Everyone know ginger. Okay, ginger also can be the can enhance the secretion of insulin and facilitate uptake of glucose in skeletal muscle. Okay, so that they use oral ginger extract, and in order to improve on the uptake of glucose and can impact glycolytic process of kidney and liver. It is good for the anti-diabetic because it increase the insulin secretion. Okay, so and this is the talk about the principle of using the traditional Chinese medicine. Chinese medicine that they use for the holistic, we call holistic approach to health and prevent disease. Also for the people who already have like a synthetic drugs to prevent the diabetes or to treat the diabetes, and they can use this traditional medicine to improve their health. Okay, because the Chinese medicine that believe that DM is a result of imbalance in the body, involving disruption of the flow of qi. Qi is mean the energy, vital energy, and the balance of yin and yang. Yin and yang is mean hot and cold. So the medicine, Chinese medicine, either medicinal plant or herbal medicine that can try to control the balance of yin and yang, or hot and cold, or control energy. Traditional medicine aim to restore harmony and balance in the body that promote overall well-being. Okay, some study there are many study that study the benefit of using traditional medicine for DM. And however, when they use traditional medicine, the people who use traditional medicine, and they might have to combine or integrate with the modern medicine, okay, they have to consult the healthcare provider. Okay, so in order to see the effect or the, because some both of the traditional medicine and modern medicine might have interaction. Okay, so and they might have some side effect or adverse effect. So we have to encourage patient to talk to the healthcare provider or talk to the nurse or the physician or the pharmacist related to the medication that they use. Okay, these are the effects of traditional Chinese medicine in general. The first one, reduction of the digestion and absorption of carbohydrate by inhibited alpha glucosidase and alpha amylase, then blood glucose can reduce. And number two, protection of pancreatic beta cell and increase the body ability to synthesize and release insulin. Okay, and then the third one, traditional Chinese medicine, increase the body sensitivity to insulin and reduction of blood sugar level by improving glucose and lipid metabolism. Reduction of blood sugar by increasing synthesis and storage of glucagon in liver and muscle. Prevention of organ damage caused by diabetes through the strong antioxidant ability. Reduction of tissue inflammation and protection of damaged tissue. These are the outcomes that we need in order to treat to manage DM, and also the medication, traditional Chinese medicine or any traditional medicine or herb or medicinal plant that we use in order to get these outcome. Okay, this is like a more detail how traditional medicine can use to control blood sugar. Okay, so the first one, energetic imbalance. Traditional Chinese medicine view diabetic as a condition that involve an imbalance of body energy. Okay, particular disruption of qi mean energy, and imbalance of yin and yang, hot and cold. If you can see some food is we call the food for cold. Some food is the food called hot, right, for warm. So when we get we get hot, we get warm, high fever, high temperature. It means our body is warm. So we need the plant or herb or the food that we eat to balance. Okay, like we will use the corn, the food with corn food. It's not mean corn food, it mean the effect of the food that it's effect to cold for the body and then can balance the energy. Okay, so and this imbalance, energetic imbalance, it rather affect function of organ, including spleen, pancreas, and kidney. So Chinese traditional medicine also have to balance the between balance energy, okay, and to promote normal function for this organ. The second one, pattern differentiation. TCM practitioner diagnose and treat based on pattern differentiation, differentiation among the person. Different pattern of disharmony in body are identified and treatment are tailored accordingly. Okay, it's different person individually have different like energy or individual difference. So when they provide medication or traditional medicine, they have to give to the person, that person individually. Okay, each person might have different medication. Common pattern in diabetes may include Qi deficiency, Yin deficiency, Qi stagnation, or blood stasis. Okay, this is the principle that they use for traditional medicine. and herbal medicine. TCM often employ combination of herbal remedy. When we talk herbal remedy, it means one medication might compound with many herb, not just only one kind of herb. Okay, that to address the specific pattern identified in the individual. Okay. And some herb commonly used for diabetes in TCM includes Wong Chi. This kind of plant that they use to have Wong Chi, and Chan Yao, this is Chinese Yan, and Cheng Dai Huang. These are the medication that they use. Okay, and then traditional Chinese medicine or you use acupuncture that used to balance the flow of qi, and some acupuncture points believed to be particularly relevant to diabetes treatments. Okay, the goal is to improve insulin sensitivity, regulate blood sugar level. Okay, acupuncture can use for like regulate blood sugar level. And dietary therapy. Okay, so they use many kind of medicinal plant or some herb that can like use as a food in order to balance yin and yang or to flow of qi of energy. Okay, and they might use this one Tai Chi, Chi Gong, Tai Chi, Chi Gong and Tai Chi. This one is in order to like a practice meditation, like a mind and body practice. Okay, involve coordinating movements, breath control, meditation. Okay, they always use to improve overall health, reduce stress, promote better energy flow. Remember the cause of DM from insulin resistance, from oxidative stress, right? And the dysfunction of glucose and lipid metabolism. Okay, so when we use treatment for DM, okay, we have to like to reduce those stress, right? This kind of meditation or my body practice and to reduce stress. And then the seven is lifestyle recommendation. Okay, so lifestyle like stress reduction. We use stress reduction technique, exercise, okay, in order to support overall health, and eating, sleeping. Okay, those are the traditional medicine that they use to treat DM. Okay, so in general, results of the traditional medicine suggested Chinese herbal medicine used alone or in combination with other Western hypoglycemic agent like a drug like a metformin or kind of drug that the physician prescribe to the patient. Okay, and lifestyle change with in order to decrease hemoglobin A1C, blood lipid profile, okay, and BMI. So that is the intervention that we provide. We might use the combination of traditional medicine and also Western medicine or modern medicine. Okay, we combine in order to decrease hemoglobin A1C, decrease the blood glucose, decrease blood lipids, okay, or BMI. Okay. Pharmacological and toxicological aspect in clinical use. Okay, since there are many traditional medicine that use now, and they have research evidence to show that there are correlation and interaction between herb, pharmaceutical toxicity, adverse reaction, quality assurance and herbal medicine standardization, they try to study and have the like a combine the medication, traditional medicine, modern medicine, and others, other activity, other treatments in order to control the blood sugar or control DM. Okay, so this is example for Thai traditional medicine. Okay, in this presentation, I just point only Thai Chinese traditional medicine because it's very famous and well known. Everyone know, and also Thai. This is for Thai people. Okay, and then for Indonesia. Okay, only 3 countries that I use information to present this time. Okay, some Thai traditional medicine, some Thai traditional Thai practice make complement conventional treatments under guideline of healthcare provider. Okay, so even the patient, the patient with DM, they use some Thai traditional medicine. Sometimes they don't tell the truth to the nurse or to the physician that what kind of Thai traditional medicine they use, because they afraid that my healthcare provider might criticize them, because they believe that healthcare provider always prescribe the modern medicine, right? And then only modern medicine cannot answer the life of the people. Okay, so some people they use both traditional medicine and modern medicine, but however, we have to encourage to talk to the people or to patient with DM to tell the truth, and then we can help them to make a plan to combine traditional Thai medicine and also modern medicine. Okay, but it's still limited information. Okay, so we don't have the we don't have the what we call the complete or success sets of treatment by combining both traditional medicine and modern medicine. We don't have those one. Okay, even we have traditional medicine that treat for the diabetes, but some people they use traditional Thai medicine only, or some people they use modern medicine only. But for the combination of both modern and traditional Thai medicine, we still don't have the evidence base, okay, from research. It's crucial to emphasize that approach should not replace prescribed medication or medical advice from healthcare provider. Traditional practice may vary, and what work for one person might not work for another, because the patient have individual different rights. It is essential to prioritize evidence-based medical care and work collaboratively with healthcare provider to manage diabetes effectively, like how to combine what kind of medicine that combine from modern and traditional medicine. Okay, this is example that we can say this is a medicinal plan that we use to prevent diabetes or to treat DM. This is a bitter melon. Okay, you see, there are many some kind of herb that can use for diabetes. Okay. Okay, this is for traditional medicine. The first one, herbal remedies. Okay, we use like a herbal compress and herbal steam, like a bitter melon, as we know that use to prevent to control blood sugar, and this one also increase the what's that to reduce some inflammation. cinnamon. Okay, so we also use to improve insulin sensitivity. Thai massage. Okay, we also use Thai massage. But actually, this one is not directly for diabetes, but this one for managing stress, right? As we know, the DM also involved with the stress. So we use Thai massage also can improve the blood circulation, reduce stress, and promote well-being. Might help to control DM with other kind of medication. Okay, dietary practice. Also, we also have a traditional Thai cuisine that have many medicinal plants that used to in the food. Okay, that one can help for like reduce antioxidants to reduce inflammation, and also some kind of food that have like a low glycemic index. Okay. And then my body practice, that is a practice meditation, for example, yoga, that used for the part of Thai culture, and also reducing stress, improve mental well-being. That is the important to manage DM. Okay. Okay, next is the traditional Indonesian medicine for DM. Okay, there are many. Okay, that you can see the example, the that effect to at the intestine, like to reduce the absorption of glucose, and also have some effect to the pancreatics, or effect to the liver, effect to muscle. Okay, so you see this one effect to liver, this effect to intestine. Okay, this one the anti-diabetic compound. Okay, this is the bitter melon, but I don't know this one. Okay, but this example of the traditional Indonesian medicine, effect to pancreas, increase insulin secretion, effect to adipose tissue. Okay, enhance glucose uptake, and effect to skeletal muscle, increase glucose uptake. Okay. Indonesia, or a rich biodiversity and ethnic group, apply for traditional medicine and anti-diabetics. Numerous ethopharmacological survey were conducted on medicinal plant in Indonesia. Indonesia, or the many island, right? And then might have different geography. So, and each place might have different, and those are the plant in each area can use for DM. From this study, just recent study from last year, a total of 229 medicinal plant species belong to 70 family used for treat DM. Okay. And for example, this one, Atheraceae and Orthosiphon. Actually, this is the name of the plant, but this one the name of the species. Are most dominant plant family and species in the in Indonesia. They use leaf and boiling. It's most applied plant part of for preparation to use at the traditional medicine in Indonesia to treat DM. And also this one like you might know that Jamua Python, Python, that is not only one herb or medicinal plant, but Jamua is the compound, right? Compound maybe from other many kind of plants, but mainly prefer from this one, Andrographine penis paniculata. Okay. Jamuapyten is a polyherbal formulation commonly used for traditional Indonesian medicine. Okay, that used to manage diabetes. Okay, and then they have the, they use, this is the TPC, stand for total phenolic content. That is like an indicator that they use for traditional Indonesian medicine from three Jamuapyten formulation. Okay, that extract, they have two way of extraction. Extract by water and ethanol, and both of them can, from this method of extraction, they can use Jamuapyten to for DM management. Okay, and effect variability of L6 skeletal muscle and INM5F pancreatic cell. Okay, they benefit for both effect at muscle and also effect at pancreatic cell. The study support the use of Jamuapyten for traditional management for diabetes in Indonesia by stimulating glucose uptake in the muscle and improving insulin secretion in beta cell. These are the just study this year to show the result. This is from research evidence, show the result that benefit of Jamu in order to control DM. So the conclusion of the traditional medicine or Asian traditional medicine, okay, they use as the plants, like we call medicinal plant that they use for food. Like we can eat medicinal plant, that those kind of food can help us to prevent DM, okay, also can control DM. And also this kind of food can reduce oxidative stress, can increase our immunity, and also reduce inflammation. Okay, so, and also we use medicinal plant or traditional medicine. Okay, and also we might have some combine many plants together and to make like for the drug. And also they can use a combined traditional medicine with the modern medicine. Okay, so, but we have to study the effect of we call pharmacological effect. Okay, for the plant that widely used for the diabetes treatment, and there are many studies show that the effect of medicinal plant that can use to control DM. Okay, WHO, World Health Organization, also point that DM prevention that is complication is a major challenge for the future. Okay, since only modern medicine might not answer the life of the people, and traditional medicine or medicinal plant that we can eat at the food every day can help us. Okay, it would be a dream if we eat food every day and prevent any chronic disease like a DM. Okay, so when the food that you eat, you have to think about it. Okay, do we, like today, do we eat medicinal medicine today, and what is it? What the benefit of it? Okay, what pharmacological effect from those plants that we eat? Okay, and then can prevent the chronic illness, because chronic disease like a DM is happen, it's occur based on our behavior, eating behavior. Okay, and herbal medicine and extract from Chinese herbal medicine also cannot replace existing diabetes medication, but in a short period. But we think about the in the future or in the long run, that how these medicine, either Chinese medicine, Thai medicine, or Indonesian medicine can help to reduce the burden of treatment for the patient. Okay. However, using the combination between traditional medicine and modern medicine should be consult the healthcare provider, and also further research should be conducted in order to see the effects, the side effect in the short term and the long term. Okay. Thank you very much.
Yeah. ขอบคุณครับ
ขอบคุณ
Dr.
ครับ
Chintana. Thank you so
ขอบ
much
คุณ
for
ครับ อา
sharing
จาร
with
ย์
us.
ขอบคุณครับ
Thank you so much for sharing with us about Asian herbal and traditional resources in diabetes management. That was very insightful, especially for those who have concern in pharmacy. And I'm pretty sure there are more potential herbal resources to help us deal with diabetes, and we just haven't found it yet. All right, Dr. Chintana, we would like to please just stay tuned here and not leave because we still have Q&A sections. Okay, moving right along to the last but not least speaker. And the third speaker is kind of mesmerized me and surprised me because she was born in Surabaya, Indonesia on 8 December 1978. And on her profile, she said she able to talk Indonesia. Let's find out. Okay. Yeah, her name is Dr. Laura Karelia Resanin. Had some training in general surgery for 2 years, and then in neurosurgery for 8 months, and in pediatric surgery for 6 months. In Temple University Hospital, Dr. Resanin completed her 6 years training in pediatric after finishing her residency in Kantahame Central Hospital and Temple University Hospital. Apparently, I spelled it wrong. And currently, she is under training to be a pediatric gastroenterology and hepatology in Temple University Hospital, Department of Pediatric. And Dr. Laura Resanen has experience working in a board as well. She was involved in Rotary Doctor Bank of Finland and worked in Marangu Hospital, Tanzania for 3 months. And she also a researcher, part of Finnish Health in Teens, FinHIT research group of the Folk Health and Research Center in Helsinki as a PhD student, and got her PhD in May or just last year, 2022. And here in her research, she was focusing on environmental risk factors that may have the capability to influence the gut microbiota and in that way promote the onset of autoimmune disease. Hello, Miss Laura Reisnins. Can you hear my voice?
Yes, I can hear your voice. Can you hear mine?
Yeah, crystal clear. Thank you so much
Good.
for joining us. Is it right? You were born in Indonesia?
Yes, I was born in Indonesia in 78, so a while ago.
Yeah, it's a long time ago, and I'm still okay. Thank you so much, and yep, you already share your screens. The role of public awareness and community empowerment in preventing and managing diabetes. Okay, Dr. Laura, the time is yours, please.
Yeah, thank you so much. Today we have heard so many topics and talk about diabetes, what it is, what are the cure and management, stem cell transplantation, and nutrition, and so forth. I'm not focusing on this topic, but I'm going to focus on the public and how to make the public aware, because that has a huge role in managing diabetes. We have seen this diabetes around the world, in Western Pacific, Southeast Asia. The amount of diabetes is plenty. And if you want to see by country, then in Indonesia, it's around pink, so it's 10 to 20 million. In Finland, we have mostly type 1, but also type 2 diabetes. Our population is only 5 million, so that's why we don't have that many people having diabetes. What does this mean? It means that diabetes is responsible for about 6.7 million deaths in 2021, so 1 every 5 seconds. And in Southeast Asia, it's over 1 in 2 adults are living with diabetes undiagnosed. This is interesting, like when we have COVID, the whole death from starting of the COVID until yesterday, I updated this number is 6.9 million deaths, and diabetes is responsible for 6.7 million in 1 year only. So the death caused by diabetes is actually more intense than caused by COVID, while the hysteria is more due to COVID than to diabetes. Top 10 countries with diabetes in 2021. In Indonesia is number 5 in the world, and approximately maybe 2045, it's a similar number. And the proportion of total deaths related to diabetes among people under 60 years old, this is like mostly it's, of course, age has the influence of it, but Indonesia is about the 6 to 9% of deaths is due to diabetes. And of course, the deaths about like 6.5% is in 2021 is about 236,000. And again, compared to COVID, you can estimate in Indonesia how many total deaths is 100 in 2020. So far is half of what diabetes has killed in 1 year. Of course, it's not mentioned like if people who has diabetes has COVID, like which one is the cause of death. But as you can see, COVID hysteria, and with half of the death of what diabetes is actually killing in Indonesia. Indonesia has also this problem that there's a lot of undiagnosed diabetes. So it's number 3 of those. Of course, if you see China, India, Indonesia, both like all 3 has a lot of people. They're like population rich. So this is one contributing factor to this finding. But then again, Finland tops the type 1 diabetes incidence in pediatric type. So it's the young type of diabetes. We have that the most in the world. I have done my PhD research on this topic, and I still have no idea what's the reason behind this finding. But in Indonesia, the data for type 1 diabetes is still to be investigated. So there's plenty of data on type 2, but type 1 is about mostly still question mark. What's the prevalence of that? This actually is in Indonesia. But nevertheless, the health burden due to diabetes is significant. This one also we talked before about the neuropathy, retinopathy, and so forth. And diabetes is rapidly increasing in Indonesia. In 2045, it might be not double, but compared to 2011 is not even double, but like 1, 2, 3, almost 4 times. So there is a problem that we have there. Diabetes is more common in urban areas. So this urban is the red one, the rural is the yellow one, and mostly it's related to aging. But then the question mark, if you see a chart such as this, is that can increasing diabetes prevalence is actually related to urbanization? Means like when the countrysides are developing more to city-like, would that be related to diabetes? And what is the role of physical work in the rural area when people are actually doing a lot of physical work during their day to gain their food, to do some farm works, while in urban areas, most work might be related to sitting in an office. So we don't have to pinpoint that to prevent diabetes is crucial, but how we be able to do that? This is Fontaine et al. Made a summary of what they think might be a good intervention for diabetes prevention in Indonesia. I won't go over all this list, but I'm focusing on these three. So empowering patients, increasing awareness, and upgrading well, my topic is number 6 and number 7, empowerment and increasing awareness. So basically, in other words, how to educate the public. And to educate the public, you have to educate the healthcare professionals to educate the public. And in that sense, number 5 is related to number 6 and 7 intensively. So challenges regarding awareness, there are like 3 different levels, starting with the patient. So sometimes the patient are not aware of the diabetes symptoms. So people just think, yeah, this is nothing, and diabetes can start even without any symptoms in the beginning. So it might patient, when they finally come to doctors, they have late diagnosis or improper diagnosis, and many have already developed several complications, such as neuropathic symptoms may often be the cause of coming to doctor even, and then they found out that, okay, it's actually due to diabetes in the first place. And there might not be the patient has not received comprehensive diabetic education programs, so they're not familiar with what diabetes is, or there's poor compliance in medication. So if they get some medication and they feel better, they said, okay, I don't need to use this medication anymore. It's expensive. It's a waste of money. So they stop using the medication when they feel better. So the diabetes will get worse after that. And sometimes also there's a tendency to, they feel better. They feel that, okay, I don't need any follow-up with doctors anymore because it's pricey. I don't have any health insurance that could cover the cost, so I don't need to go to the doctor because I don't have any symptoms. And that too is causing that the diabetes might progress and have a worse end result. Then the second challenge regarding awareness is the awareness of the healthcare professionals, namely the doctors. This might be in Finland. There are also variation on like between professional competency, tiny, but there is. But around the world, there can be like different level of understanding of diabetes. Even the diabetes is developing so quickly, so maybe like my knowledge that is 10 years ago, from 10 years ago, is not up to date today anymore. So doctors have to keep on learning to keep themselves updated of what the standard treatment guidelines are, because they are improving due to research findings all the time. For instance, this is based on the Fontaine's research that in 2016, even though almost 90% of doctors are aware of the guidelines, but only 20 to 35% actually implement them with patients. And then there's also might be due to difficulties to access guidelines regarding diabetes or unequal training standards. There's also the problem of diversity in distribution of health services. So in 2022, Indonesia has 6.3 doctors per 10,000 people, and WHO recommends 10. And like it's the minimum, and if the country has less than 25 healthcare professionals, it's a kind of challenging. It's not impossible, but it's challenging to achieve the WHO's Millennium Development Goals. And it's not just the amount of doctors are it can be more than what currently is, but the uneven distribution of doctors. So in Indonesia, I think based on the map, Jakarta and Bali are the popular areas, but in the rural areas, in Eastern Indonesia, the amount of doctors are not, or the density of doctor is quite few. So this WHO recommendation, of course, it's covered in Jakarta and Bali area, but not necessarily in the rural areas. And not all health centers, puskesmas, especially in the rural areas, have resources to screen, diagnose, treat diabetes. Do they have this blood glucose, like every rural area does have that blood glucose test, urine test, not mentioning this long-term HbA1c test. So here you can see from the Index Mundi how many physicians per 1,000 people are in Indonesia. That's the blue one here. And Malaysia is this one. And the world is this one. So it's if all the world is summed up together. So Indonesia still has pretty low amount of doctor per people. Indonesia is vast, is huge country. I know that it's impossible to cover almost the whole country. It's a good thing that at least we have enough doctors in the densely populated area in Java, but still it might need a bit more doctor to achieve this more awareness on diabetes. In Finland, we have enough doctors, but then I can tell you from personal experience that Finnish doctors are just overloaded with work as well, because they have to do all this digital and paperwork that is out of the patient clinic. At least in Indonesia, when you're working as a doctor, you focus on clinical work and not, let's say, getting the garbage from the office and then delete it because it has patient record just due to security data protocol and so forth. And this is how many doctors are there in Indonesia per 100,000 population. As you can see, I think this is Yogyakarta, Bali, and then Jakarta. They have the most doctors, but the red areas are in the eastern Indonesia. It's still lacking doctors. So what the public has to be aware of. So of healthy lifestyle, we talked a lot of this, so I won't go into deeper on that. But this is like the government has, I found that have these two different program from the Ministry of Health, Patuh and Cerdik. So both, like there are several things that are similar in both programs. For example, routinely check up with a doctor, and then diet. We talk about that one today, and physical activity. So some of them are similar. So that's a good way to increase the awareness, just having such posters laying around in the public places for people to read and to see. But this is about hypertension, but why not about diabetes as well? Like what diabetes is, similar way can be used to educate the public. And this is awareness of type 2 diabetes risk factors, and this is a poster from PACE hospitals. So what are the risk factors for diabetes? So when people are waiting for different appointment to doctors, so they can sit down and just read at the posters and see, oh, I actually have that. So maybe I'm I have risk factors for diabetes. And aware of early symptoms. So this is the poster from Vietnam. It's one example of how to be aware of early signs of diabetes that can be used. And losing weight, feeling tired. So if people are reading that, see if something just hit, oh, I do have symptoms. Maybe I need to go to the doctor to check whether I actually have diabetes. So posters, a lot of colors, interactive posters, something that attracts the vision, that might help with increasing the awareness occasionally. And also, since many people are leaving social media, maybe posters that are or advertisement that would just jump up in Facebook or in Instagram about this type 2 diabetes. Then we need to be aware, or the public need to be aware about the importance of clinical follow-up, the role of HbA1c as long-term glycemic control. People need to know what are normal glucose level, about that daily glucose measurement is just not once in every 3 months. It's not enough. It has to be like daily checkup. And for example, in Finland, we often use this type of mobile application. It's called LibreView number 2. It's so you, instead of measuring from the fingertips, you just put a sensor on your hand, and then with the machine or with your phone, then you can see what your current blood glucose level. So you can check it 20 times a day if you want. So that helps with the continuous censoring to be aware of what your glucose level is and what your goals are. And as research-wise, it's important to be aware of the nationwide follow-up using public data. Are we even close to our goals? So if every physician is trying their best to deal with diabetes, like in my area, are they even close to our goals in the whole Indonesia? Like which Indonesia's areas are struggling the most? And maybe that region needs specific intervention. So Indonesia is very diverse. There's so many ethnic groups, so many languages, so many islands, so many different level of infrastructure. So it might be that one thing that might work in, let's say, East Java won't work in Flores, for example. So what's the regional regional struggles people are experiencing, and how to deal with that specific area? And of existing treatment and their availabilities, I won't go deeper into that because I think we have not much time, and we've talked most of this lifestyle and modern medication a bit. But then again, what if of the existing treatment includes, let's say, patient support groups? So when someone is diagnosed with the diabetes, then they can join a Facebook group of people or patients with diabetes that could share online their experiences, maybe some beneficial web pages, some doctors that they attend to, what the doctor said. So it's just like a social, either a real social group or an online social group for sharing. So how to increase the diabetes awareness of the public? With the posters and the social media is one way that I've mentioned before, but then it can be still more challenging in the rural areas where less education resources are available. If there are still problems on how to read, then it's not simple to increase the awareness with printed posters with writing. So it needs another way to do that. And telemedicine has been developed a lot during COVID. There's online doctor chat services that has come up in Finland within the past 2 years is plenty, and it has boosted during the COVID-19 pandemics. So people can actually chat from their phones to have an appointment with a doctor and just ask the doctor about their symptoms, what they should do. Or I think this is in India, there's this walk-in health clinics with computerized self-service kiosks using artificial intelligence, offering medical protocols approved by the WHO. So they just can feed their problems to a machine, and then the machine would just using AI to analyze like what probably could be their diagnosis, their problem, and to which doctor they should go. And this is some in Southeast Asia. I don't remember where, but there's, for example, buses equipped with medical devices, screening technologies, maybe even bus doctors that would go to rural areas that has not in remote locations, and would have if the doctors are not there available, then the patient with maybe some nurses can do video conferencing while entering that bus with specialists, referrals, and have follow-up with visits. So it's not necessarily, if there is no Puskesmas there, then these medical buses can go there and give the health services. In the Finnish model, the screening for type 2 diabetes is pretty common during regular checkups. So most people do when they turn 40 or before they are accepted on a profession, start a job. They were asked to the occupational health to undergo a general health checkup. And most of them, if they have this potential type 2 diabetes risk factor, will be screened for type 2 diabetes. And this can be performed independently by nurses as well, so it doesn't require doctors to do. And then again, in Finland, there are relatively easy access to healthcare providers. Yes, we're complaining that the queue to get a healthcare professional is long in the public sector, and the private sector is still expensive, but relatively, it's not that impossible to get a doctor within 2-3 months. And in Finland, there's also web pages for digital community that provides comprehensive research-based information. So the nurses, if they don't have time to tell the patient, oh, you should do this, they would just give the web page or link to that, and then the patient can go and read by themselves. We have Finnish Diabetes Association that provides training, education, and courses for diabetes in different cities all around Finland. So I'm sorry, I could not open the link apparently. And then when the patient is diagnosed with diabetes, it's not just the doctor that's treating the patient, but they will get the whole lot team behind them, which includes the doctors themselves, diabetes nurses, nutritionists, psychologists, this chiropodist, so the one that's treating their feet, and physical activities instructor, exercise planner, to get the whole package of how to treat or how to deal with their diabetes. And in each step, well, Finland is the country that likes to educate their people. So in each step, they usually ask the patient, like, how far they know about their own disease, about their, like, what are they not aware of. And then from that point on, they start to increase their information on diabetes until the next step. So when they meet the next healthcare professional, they already have some idea how to proceed with their knowledge. In Finland, we are also pretty research addicts oriented. So in 2003, this is one example of awareness that I'm going to use. In D2D is a research that's or is a governmental project that is done in 2003 to 2008, and the aim is to reduce the incidence and prevalence, of course, that the first aim, but it's also aiming to identify by individuals who are unaware of their type 2 diabetes, why they are unaware of it, and how to increase the awareness for those who are not aware of it, and to evaluate the effectiveness of different programs, awareness, and to generate regional and local models and programs in prevention of type 2 diabetes. So it's the populational strategy, try to cover the high risk strategy, and early diagnosis and management. And this program, it's not just made for a program itself, but it was evaluated later in 2012 by this Rautio's study follow-up, and the conclusion is the socioeconomic status modulated the interventions, and if someone's giving some intervention is worked pretty well in especially in lower socioeconomic status, but the participation in group intervention is still low. The result of this intervention, as you can see, it was 2003 to 2008. This is the incidence of diabetes, type 2 diabetes among the blue one is men, the green one women, per 10,000 people. And it was starting to increase and increase and increase, but after the intervention until 2008, then it started to decrease again. So apparently, whatever that this national project is actually succeeding in this, reducing the amount of diabetes incidents. But this is the importance of, so this motivates people, motivates healthcare providers. Yeah, we can make it, this happen together. So it's this is data based on this Finnish Institute of Health and Wellbeing, which is dedicated to informing the public and to do research on the public. So THL is the one who gives a lot of information to the public through news, through newspaper. They contact and producing health news for the whole Finland to read, and that's one information channel that has been quite productive. Then Finland has this Oma Kanta, that is an online health records. So whenever a person goes to a doctor, then all the diabetes related problem will be documented and it will be uploaded online. So the patient himself can go and from their smartphone check their patient record that has been written by the doctor. Maybe let's say 3 months ago, the ABH1C was, let's say, 58, which is pretty good. And then 3 months later, when he was checked and okay, it's 78, then the doctor asks, so what was it last time? If we go to the different doctors with different records, then he won't remember, or maybe like no one knows. But with this online health record, then the doctor and the patient can actually check wherever the patient is, whether he's in Helsinki or in Oulu, which is up north. He can see like what the past appointments was all about. So it's kind of a continuous story of the health record online, always available to anyone that's treating the patient. So this has been proven to be a very efficient way to deal with, to continue the treatment. So it's not just like go back and forth, but to see the progress regarding the patient's treatment. And this is a latest paper by Lakta that was published in Lancet about the effectiveness or digital or group-based lifestyle intervention compared to usual care, so with the previous normal care. And the result is the digital group, which means that they will download an application on their health and then go to the more conventional, so have a group meeting with people, and that has a pretty good result compared to just the control with no online, no application that they can follow their progress themselves at home. Then the second part is how to increase the diabetes awareness of the healthcare providers. Easily accessible online training program and diplomas, maybe online conferences such as this. And this is also important, building online nationwide consultation network. So doctors need to, like, no one person can cover everything. So no one person can know everything. So if one person knows something and then they can combine their information online in a pool of medical information and consultation, that would be the best way to learn themselves from other people through case studies. And building a technology-enabled decision support tools, for instance, providing access to up-to-date. In the Finnish model, we have this online database called Käypä Hoito, where doctors can go in and check for what's the latest guidelines for diabetes. If there are any new medication, what are the indications to try the new medication, and so forth. And this is also have a license, but the employer usually would pay for the license. And UpToDate is similar, but an international version, and that's usually made available whenever possible. So in this way, by reading these guidelines, by reading UpToDate, the doctors would educate themselves continuously to what the latest trend could be. But the question is, who should increase the public awareness? Who should empower the community? Especially in Indonesia, are there enough medical resources to do this? Does it have to be doctors? Does doctors have to be the one who is increasing the awareness? Are there enough technology distribution in urban versus rural areas? Are internet availability even equally distributed? The question is, would increasing the amount of doctors be enough to increase awareness to empower the patient? Does it have to be doctors? Because educating doctors is expensive. In Indonesia, I checked that it's 15 to 50 million rupiahs per semester. That sounds a lot, and it takes a long time. And how many doctors are committed to live long-term in rural areas after they graduated? And basically, doctors seems that they are overqualified for focusing or awareness only. Like in Indonesia, if the doctor's amount is 6.3, they're really busy treating patients, and all the time are needed to treat patients. They are sick. People get sick and they need doctors. So the time resource is limited to educate and empower their patients during the doctor appointment. And not all doctors have time to do research on diabetes. Some have time, but then that's off their clinical work. If they're focusing mostly on clinical work, they don't have much time to do research. So that this is the dilemma that doctors most often have to face. And then how far the technology being distributed, we talked about this accessibility to technology. And then can we recruit non-medics for public education purposes? So if we need to educate the public, make them more aware of diabetes, are there, let's say, public health generalists that can be recruited for this? Food and nutrition professional, environmental health officer, occupational health officer, community health workers, psychotherapists, health volunteers, anything other than doctors. Do we have them in Indonesia? I'm not sure. I have not, but you probably know better on this sector. But then the other interesting question is, what about the concept of physician's assistant? Could this be a potential solution? So what is a physician's assistant? In the States, there are commonly, this is a well-known concept. I think in Malaysia, correct me if I'm wrong, there's also a physician assistant in Tanzania. I've bumped into physician assistant in Ethiopia as well for working in rural area, but I'm not sure if it's still existing in Indonesia. So PA, a physician assistant, can perform some medical operation. They can examine the patient. They can diagnose illness. They work together with a physician, but most of them actually work independently. So they're more trained than nurses to deal with diseases with medication. They can prescribe limited numbers of medication, not the whole arsenal. They can interpret X-ray, for example, but they're not as overqualified as doctors to work in rural areas. And they can focus on research. They can focus on advising patients, dealing with preventive care on this subject. So can such a new field of education be considered from the rural areas, for the rural areas? In Malang, there is this idea that it's a education program for teachers. So it's a transformation. The idea is they take teachers from the rural areas, educate them in Malang, and after they're finished, they give them good education and then send them back to the rural areas, to schools that they have established in the rural areas. So why don't this system work with medical? Let's say if there's a physician assistant, when people from the rural areas know the language, the culture, the norms, is familiar with health issues in their own area, they had a ready-to-use network, and usually they feel like when they come back after educated in Java, they feel like, yeah, this is our own people in the rural area. They might estimate what might and might not work. So this is sometimes I've just for fun imagining if there were like 4 to 5 year education program to train high school graduate from rural areas to be a physician's assistant. This would be the training areas that I would like to train them with, especially concerning diabetes, on nutrition, on epidemiology, hygiene, first aid, prevention medicine. So they have theory in university for 3 years, then internship in rural area for 1 year, and then return back, and then another more specific finding for 1 year. 4 to 5 years, not as long as doctors, but then they will have the ability to empower the patient on nutrition, on simple medication lifestyle, and to follow up their intervention, to do research on that area, the epidemiology. How would this intervention work in the rural area? Can we use this? Do we have to switch to some other, make it effective? So after graduating, they can deal with several health problems, including diabetes, involved in the community, and aware of medical problems. So in summary, public awareness of diabetes may lead to less diabetes complications since people can contact health providers if it's way too late. And community empowerment would keep patients motivated in continuing their treatment. So if they say like, yeah, I don't need any more, but if the public is aware that like, no, you should continue your treatment, and then it's public then can educate each other, then it can empower the patient to and motivate them to continue with their medication. It may have, for sure, awareness would have many health benefits, but to increase awareness, it would require more resources from the healthcare providers. And the question is, should doctor be the only ones to educate the public? What about other healthcare professionals? Or would it be, we would go so far to establish a whole new educational training program to start educating physicians' assistants to go especially to the rural area, to be a potential answer to lack of doctors' resources in that area. Yeah, that is my questions for us to think about, and these are the references. Hopefully I'm not too much out of time. Yeah, thank you.
Well, thank you so much, Ms. Laura. That was stunning presentation. The data that you've shown on the early slide was alarming us as an Indonesian health professional. Like, we gotta do something to knock off the number as predicted on 2045. And one of the strategy is empowering the community. Thank you very much. All right, ladies and gentlemen, now we're on Q&A sections. Like I was saying, if you want to ask questions, just raise your hand, or you can ask your question through the chat box. Okay, this is the first question for Professor Liesel from Maya Destira. Okay, Professor Liesel. Hello, you still here?
Yes.
Okay, this is question for you. What is your point of view about the keto fasting that often considered good for diabetes patients?
Okay. So I think this has something to do with the ketogenic diet. It's my first time to hear about the keto fasting. But if it's something related to ketogenic, that means the high intake of fat and a very low level of carbohydrate, then it has been well recognized already that ketogenic diet is a fad diet, and it is not good for patients with DM and to everyone. So when it comes to weight management, if the aim is to lose weight, then the healthy way is to reduce the caloric intake and to increase the physical activity. And for some people who are really obese or morbidly obese, then I think medical doctors can advise weight loss medication to aid in weight management.
Okay, thank you, Professor Lizold. Hopefully, Miss Maya Destira still join us and hear the answer of her questions. Okay, maybe we have next questions. Yep, still for Professor Lizard is from Mr. Gurit. You mentioned that protein induced decreased glucose uptake. On the other hand, you mentioned as well protein transport glucose in the blood. It means will increase. What do you think about that?
Yes, based on my reading, there are three transporters of glucose, one located on the other side of the membrane and the other one on the other side. So I think for the recent findings on active peptides, which is a byproduct of protein digestion, it's acting on one of these two transporters that regulate the uptake of glucose. I'm not really sure the specific transporter because I don't want to be mentioning wrong information, but there are two, and the one that regulates the entry is the one that is influenced by the bioactive peptide from a byproduct of protein hydrolysis.
Okay, thank you very much
Thank
for the
you.
answer. Okay, we have someone who raised his hand, Mr. Johannes William Saleki. Please, on your mic.
All right, thank you very much. Can you hear my voice clearly?
Yep.
Okay, thank you very much, moderator. I would like to ask for the after the presentations. The first one for Achan Chintana, if she's still here.
Yes.
Yeah, sorry, Kak Achan.
Yes, please.
Okay, Achan, thank you. After your presentation, I saw that we have abundant resources of herbs in treating diabetes mellitus. So, do you think is it proper for us to include the consumption of potential traditional herbs in our food-based dietary guidelines for DM patients? Because I know that Thailand have the Thai flag, and then Indonesian have the tumpeng gizi. Should we include the consumption of those potential herbs for DM patient in such recommendation? Because it is easier for people to understand that type of recommendation when we use like Thai flag nutrition flag, Thai nutrition flag, or like Indonesian tumpeng gizi or my plate, for example. That's for Achan Chintana.
Okay, thank you. Yes, yeah, for research, when we do if we do research related to the DM, people with DM as our population, okay, so we want to learn that what kind of treatment that they use, right? Either modern medicine or traditional medicine. Yeah, you should have those data to explain how it work, or maybe you can do like a control experiment to see for the control what information what's the context that they use that they have, including the traditional medicine or modern medicine, and then see how these people that can control blood sugar. So and then we can learn to compare with people or only use traditional medicine, no, modern medicine, and for other they might use both traditional and modern medicine, because like many people in Thailand, they always use like medicinal plants in the foods, and also they use in addition to that treatments, but sometimes they didn't tell us that what did they do. Okay, so for your research you might do like a interview to see that what is their context, what kind of medication either traditional and modern medicine use, and to see what and then you can explain how these people can control blood sugar or can control DM, and also can check the complication. And then you might learn that if the people have only modern medicine, or if they use both modern and traditional, and what happened to them.
So we have to understand the pattern first, Achan.
Yes,
Okay.
the context, because there are many people they use both, but they did not say it. They just tell the doctor or the nurse when they come to follow up. Okay, and then we can see, oh, is it good that you continue using this medication, then you can control blood sugar. But sometimes they have other thing, okay, in addition now to those medication that they use. So then we understand the context. But anyway, if we want to see the interaction between the modern medicine and traditional medicine, so that is further research. And there are many research now. You can read from the database. There are many research talk about the like a side effect or the effect of or interaction between the traditional medicine and modern medicine. And right now they have the commercial. There are many advertise about they advertise about that like a cordyceps or other kind of thing, but we don't know exactly that is that proof from from that already prove or not that it's good or not. And then this kind of medicinal plant is very expensive. Some people it's like they use a lot, but we don't know the result exactly. It's kind of commercial, and people in the rural or people, they don't have enough education. I mean, not enough health literacy, so they believe that from advertising and they use it, but the result we don't know. Okay, so we are the nurse, we are in healthcare provider, we should talk to the patient about the truth, about the scientific knowledge. And if they use at like a medicinal plant that we use in the food, right? That is okay, right? Because the food is not a medication. But if they use as a medication, that's why we have to do further research.
Okay, Achan. ขอบคุณครับอาจารย์ Thank you, Mr. Moderator.
We still have question, right, for Miss Laura, I guess.
Yes, I do, but maybe is it okay if I continue?
Yeah.
Yeah, this is my questions for Miss Laura, because when I saw your presentation, Miss Laura, I was so fascinated by the data that you shown to us. I was wondering, like, what roles can other healthcare professionals play in raising public awareness regarding DM? Because I only noticed that you mentioned the lackness of physician or doctor distribution in Indonesia as the challenge in increasing the awareness of DM. I think maybe we could um, use or utilize other healthcare professionals in helping achieving that too. In your presentation, also you mentioned the physician assistant. Maybe instead of doing that, maybe we can just utilize other or what we already have in healthcare professionals here to utilize them to educate the people, to raise the public awareness, especially in remote area or rural areas. If it's still harder for us to provide a doctor or a physician.
Yeah.
Thank
Thank you. Yeah, that's my this is just an idea that I threw up in the air. Like from my point of view is that I'm not totally aware like what different type of healthcare professional there is. But if let's say if there is a nutritionist, and when the nutritionist can increase awareness on nutrition, psychotherapists can increase awareness on exercise, but then maybe both of them, that we need epidemiologists to then see the effectiveness of this intervention, and then some other to report that thing on to maybe do the diagnosis. So maybe instead of one doctor to deal with this matter, you would need 4 different healthcare professionals. But if it were like we build a new physician's assistants that all of them are combined together, so it's like a doctor and has the role and have the capability to tackle the diabetes from different perspective. You just need to take one person to the rural area, and that person is already from the rural area, hopefully, and you just educate them, return them back to the rural area. So then they already have, instead of sending people that have lived in Java for their whole life, 20, 25 years, and just force them to go to the rural areas. Who would want to do that? But if it's a person that's from the rural area, educated for the rural area, with a mission that when you come back to the rural area, you should be able to do this, and they have different motivation to build the rural area because it's their home. So maybe that's more cost effective in a way to just send one instead of 4 or 5 with different capability.
Yeah, I agree with that in terms of the efficiency. I have another question. Uh, I saw that you explained about the Finnish model when they make the data available online and accessible everywhere and anywhere. It is so interesting for me. So I would like to ask, how long did it take for Finland to thoroughly apply it? Because in Indonesia, as I concerned, the government, the Ministry of Health, are starting to make the similar application too, which we call it aplikasi satu data. But I have no idea how long will it take for Indonesia to apply it entirely in our country. Just wondering how long did it take for Finland to apply it entirely in the country. Thank
So
you.
when I started as a general practitioner in 2005, we still have papers. So that was 25 years, so it's only like papers. And then in 2009, we already have the electronic patient record. So you can access the patient record from the same hospital in different wards. And then this online application, I think it's been for 2 years, like actively running. But I don't know how long that will prepare for it to work until but it has a lot of data protective restriction. For example, if it's not just everyone can access it. It's the one who has the data, and they have to identify themselves through an application that it's really themselves that is accessing. And when physicians want to access that data, they have to put a check mark. Yeah, this is for treating disease. I have a like approval from the patient, and you actually leave a digital fingerprint that so the patient can see like who has accessed their data. So if it's their friend from this and this hospital that has nothing to do with their data patient record, they can actually see that this has been accessed then and then by that person, which can each breach the security system, and they can apply a complete complement the how do you call it, have to ask for that not to do that and have a fine for that person.
Yeah, I think that would be the main obstacle for us because we are not quite good in private data protection, I guess, in Indonesia. Maybe that should be increased first in order to apply that entirely in our country. Thank you, Miss Laura.
Thank you.
Okay, thank you, Mr. Johannes. Do we still have questions?
It would be me only then. Just let the others first.
Okay, thank you.
Thank you.
Thank you. Thank you. Okay, I'll move to the next questions from Mr. Diki. Questions for Dr. Chintana. The question is, I would like to ask regarding the use of TCM herbal medicine in Thailand. What is the form of government regulatory support in Thailand in the use of herbal medicines or drugs derived from natural ingredients? Is it recommended to be prescribed by a doctor or how?
Okay. Yes. So in Thailand, we have we have medical doctor, like a regular medical doctor from were trained from like a 6 years training, 6 years study for the modern medicine, right? And then we have a Thai traditional medicine. They train for 4 years. Okay, they can do the medication. They can prescribe medication for Thai traditional medication. Then the patient they can use either they can select traditional medicine by using those medication from the Thai traditional doctor, traditional medicine doctor. Okay, and yeah, the patient can select those one. We have hospital. There are many hospital in rural area in Thailand. We call community hospital. They have the section of Thai traditional medicine. They have like herbal remedies. They have medication for hypertension, for DM, for others, like constipation, for any other symptom. Okay, so they can select this one. This is that is regulated by the Thai government. Okay, they have that profession now. And if the patient they select like a regular doctor, okay, they can get like a metformin or some kind of medication that for modern medicine that we already know, right? But for traditional Thai medicine, they have the Thai traditional medical doctor can prescribe those medication as well. But the thing is, nurse, we are nursing profession. We are the nurse, right? We work with the patient. We should know what medication, either modern medicine or traditional medicine they use. And then we have to discuss with the doctor, the medical doctor related to those medication they will use, because they have to check to see the interaction between those medication, those treatments. Yes, we have modern medicine and traditional medicine. Yes, and yeah, we have prescribed from medical doctor and traditional medicine doctor. Okay.
Yeah, thank you so much
Yes.
for the answer, Dr. Chintana.
Okay, thank you.
Yeah, that's nice answers. Do you still have questions? Yeah, this is for Professor Liesel from Miss Fauzia. There are several diet modifications for diabetes mellitus, and one of them is intermittent fasting. What does the professor think about this diet? And please explain what kind of intermittent fasting is most effective in controlling blood sugar.
Thank you for the questions. Um, diet modification for diabetes is the carbohydrate controlled or consistent carbohydrate diet. That means the patient has to be provided with a consistent amount of carbohydrate at a regular time or interval. So the intermittent fasting may not be applicable, especially for those who must be or who is on an insulin therapy, wherein there is really there should be the timing of meals with medication or with insulin injection. And the problem with intermittent fasting is that there has to be a long hours of fasting or not consuming food. So it may not be applicable, okay, for diabetic people. And if really the person would like to try, then first she can consult the doctor together with the nutritionist, dietitian on how they can plan for it. But in my understanding, intermittent fasting and takes a lot or a long, like long hours of fasting that the person will be able to consume food even though he is already hypoglycemic. So that thing can lead to hypoglycemia or a very low level of blood sugar, and that can have consequences,
All right.
health and medical consequences. So for me as a nutritionist dietitian, I stick with the diet modification that is a carbohydrate, consistent carbohydrate diet, and a very low calorie diet and a low carbohydrate diet for patients who are obese and who are overweight and obese.
All right, thank you for the answer. Okay, intermittent fasting. Yeah, this is something goes viral in Indonesia, but intermittent fasting. And then I guess that's the last question for this session. And now for all the speaker, we have certificate for you. First for this is appreciation certificate for Professor Liesel M. Atinza, RND PhD. Thank you very much for joining us today. And the next certificate goes to Dr. Cintana Wacharasin. Yeah, the certificate will send to you maybe today. And then the last certificate goes to Dr. Laura Raisenin. Yeah. Thank you, Dr. Laura. Come to Indonesia, Dr. Laura.
I'm already in Malang.
Oh,
at the
really?
moment.
Oh,
Just for a
surprising.
visit.
Oh, okay, that's nice. Yeah.
Silakan main-main ke Malang.
Oh, yeah, nice. Your Indonesian still sounds good. Thank you. I think this is something incredible how we able to share knowledge, insights, and experience with all the speakers from different country about especially about diabetes. And yep, I presume that the countries all over the world have similar problems in terms of diabetes, or let's say that we are on same boat about this problem, and hopefully we can work together hand in hand to solve this problem, and it's help professionals do their part. So thank you very much for Professor Liesel, Dr. Sintana, Dr. Laura for joining us today, and my organization, Poltekes Kemenkes Bandung, really appreciate all the things that you've just delivered to all the participants today. And Miss Witri, I'll give it all back to you.
Thank you very much for your invitation and your attention.
You are welcome anytime this Dr. Cintana Wacara sins.
Ladies and gentlemen, what an amazing sessions. On behalf of the committee, we would like to thank all the speakers. There's Mrs. Cintana, Mrs. Liesel, and also Mrs. Laura for sharing the amazing presentation and also give us a lot of beneficial insight. And also to Mr. Paizar that has been leading this session very well. We have so many questions, but we have a limited time. So ladies and gentlemen, we have to come to the end of this main session for today international conference. But before I close today's event, I would like to inform for all of you that there will be an expert session and also oral presentation on the second day of our international conference tomorrow at 23 November to 2023. So on behalf of the committee, I would like to thank all the participants as well as the speakers and moderators for all the enthusiasm in participating in our international conference. We would also like to apologize for any major or minor inconvenience. Hopefully this session will be a great benefit for all of us. It's been an honor for me and for all of us in the committee to be among such accomplished individuals and to be able to host every individual today. Okay, ladies and gentlemen, don't forget to be in this Zoom meeting again tomorrow. And see you in the second days of the conference. I'm Witri Priyawanti Putri signing off. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone.
Bye-bye. Good afternoon.
Terima kasih Bapak Ibu. Kami tunggu kehadirannya besok di sesi kedua. Masih ada expert session, masih ada produk inovatif exhibition dan juga conference oral presentation. Selamat sore Bapak Ibu sekalian. Assalamualaikum warahmatullahi wabarakatuh.